some kind of butterfly. Baby, you give me midnight. You whip up my appetite. Don't leave me here high and dry. Oh, but I don't wanna jinx it, baby. Let's not get ahead of my time. Oh, but I don't wanna miss you, baby. So I stand up and speak my mind. Oh. Baby, you give me ice and fire. You're giving me wind and rain. You're some kind of butterfly. Baby, you give me midnight. You whip up my appetite. Don't leave me here high and dry. Oh, well, I don't wanna jinx it, baby. Don't leave me here high and dry. Oh, but I don't wanna jinx it, baby. Let's not get ahead of my time. Oh, but I don't wanna miss you, baby. So I stand up and speak my mind. Oh. You're channeling wind and rain. You're some kind of butterfly. Baby, you give me midnight. You whip up my appetite. Don't leave me here high and dry. Baby, you give me ice and fire. You're channeling wind and rain. You're some kind of butterfly. Baby, you give me midnight. You whip up my appetite. Don't leave me here high and dry. Oh, oh, up my appetite. Don't leave me here high and dry. Oh, well, I don't wanna jinx it, baby, and twist myself at the spine. Don't wanna overthink it, baby. It's just twist your body and mine. Baby, you give me ice and fire. You're giving me wind and rain. You're some kind of butterfly. Baby, you give me midnight. You whip up my appetite. Don't leave me here high and dry. Oh, but I don't wanna jinx it, baby. Let's not get ahead of my time. Oh, but I don't wanna miss you, baby. So I stand up and speak my mind. Oh. Baby, you give me ice and fire. You're channeling wind and rain. You're some kind of butterfly. Baby, you give me midnight. You whip up my appetite. Don't leave me here high and dry. Baby, you give me ice and fire. You're channeling wind and rain. You're some kind of butterfly. Baby, you give me midnight. You whip up my appetite. Don't leave me here high and dry. Oh, oh, whip up my appetite. Don't leave me here high and dry. Oh, well, I don't wanna jinx it, baby, and twist myself at the spine. Don't wanna overthink it, baby. It's just twist your body and mine. Baby, you give me ice and fire. You're giving me wind and rain. You're some kind of butterfly. Baby, you give me midnight oil. You whip up my appetite. Don't leave me here high and dry. Oh, but I don't wanna jinx it, baby. Let's not get ahead of my time. Oh, but I don't wanna miss you, baby. So I stand up and speak just my mind. Oh. Baby, you give me ice and fire. You're channeling wind and rain. You're some kind of butterfly. Baby, you give me midnight oil. You whip up my appetite. Don't leave me here high and dry. Baby, you give me ice and fire. You're channeling wind and rain. You're some kind of butterfly. Baby, you give me midnight oil. You whip up my appetite. Don't leave me here high and dry. Oh, 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 oh,
You know that getting temporal bones is becoming very difficult nowadays, and this is the greatest limiting factor. Once we get the temporal bones, I am announcing the course. So that's how our courses are being decided. Unfortunately, every 4 months we are continuously organizing these kind of workshops because of constant availability of temporal bones through various means. And earlier we used to do 1 day courses, but because the time allocated for the delegates was less, many people started asking us, requesting us for a 2 days workshop. That's the reason. For the first time, we are organizing 2 days. Because to afford 1 day leave at Ments hospital is quite difficult. Our patients are always there, so we have to be there. That is the reason. That is another limiting factor. But nevertheless, we wanted to have a 2 days temporal dissection course. And in this course, the delegates are getting each day 5 hours of dissection, continuous dissection. Earlier, we wanted to have only 10 stations, but again, because of the demand by the delegates, we had to extend by another 2 stations. So we have 12 stations, and the structure of this workshop is quite simple. Pre-lunch, the faculty members are going to dissect for 5 hours to show the various procedures. The first day it will be like transcanal endoscopic and microscopic procedures by Dr. Shankar and transmastoid procedures by Dr. Shreyas and transmastoid mid-level procedures by myself. That ends today. That is up to labyrinthectomy we are going to do today. Starting from starting from simple procedures like myelinotomy, Grommet insertion, labyrinthectomy will be done today. And from labyrinthectomy onwards, up to the middle cranial fossa, it will be done later today or tomorrow. And we are there with you, and it's a small crowd.
Syringe with saline intratympanic injection on
The only
2
thing we
2
score, the faculty members score, our youngsters like you, is only that we are more experienced because we were born earlier. That's all. But updated knowledge, the technology update, all these things, you have to teach us. So it is a give and take thing, and maximum benefit, the person who is maximum benefited, maximum is going to learn it myself because I'm organizing these workshops, and that is the reason I continue to be organizing these workshops because I learn a lot of things from these workshops. Thank you, and there is nothing like a simple question or a stupid question and all these things. The mic is there, it can be circulated freely to you by our faculty member, our staff members who will be here all the time. And so you can freely ask questions and you can interact. Right from basic things, whatever it is. And if you know more than us, you please share the knowledge with us and we'll share that experience to you. Okay? Any questions? Thank you. OT, please.
Sir, good morning.
Hello, hello.
Yeah, this was the first thing I wanted. The first hello I said there should be answer. There should be nothing like hello, hello, can you hear me? All that I wanted to avoid. And I'm happy that our audio visions are working well. And all the things I want to tell you that there's no professionals involved in the audio vision. Everything is plug and play in this auditorium. It is organized by our own hospital staff who help me in the operation theater and in the so bear with me if there is any technical problems. But I should thank that the first hello, answer clear. Thank you. Dr. Shreyas?
Yes, sir. We're in the in the OT.
Okay.
We're all ready. Shankar sir is actually all set to show us the mid-layer procedures, and sir will be using an endoscope to demonstrate most of the procedures.
Yeah.
We've all seen him earlier. Also, he's an expert in this field. So we would like to gather knowledge from whatever he teaches us today.
Yeah. The formal introduction of faculty will be done in the inaugural summit. Okay. So now Dr. Shankar.
Sir, good morning, sir. Hello. Good morning, sir.
Yeah, Shankar. Am I audible now?
Yeah, you are very clearly audible,
Yeah.
sir.
You are also audible.
Okay.
So we can start. Tell Dr. Shreyas that the picture is not yet on the screen.
So now, sir.
Not yet.
Yeah, before we get the picture onto the screen, good morning, all of you. And then just few things I would like to say. I'm associated with Ments right from 2000 when I came out of the army, 2000-2001. And Dr. Pradeep Kumar has been my senior. He has been my mentor. We are close. And I used to look after his clinic when he used to go to Arunachal Pradesh. And then whatever Dr. Pradeep Kumar sir does, it's all with perfection. It is flawless. And today we witnessed that we started the program with the national anthem. That is something I have not seen in any of the workshops. At least I have not seen. That was a very, very nice beginning to this wonderful workshop. And then Dr. Shreyas is carrying the legacy of Dr. Pradeep. And Dr. Meena, anesthetist, is not there because there is no anesthesia involved. Otherwise, she is also the person who is behind all the organization and the success of this program. Sir, have you got the picture, sir?
Sir, I think it should be centered.
Yeah, you have got the picture?
Yes, we've got it.
Okay. So now, first I'll be just showing the dry bone. Okay. So Dr. Shreyas will be speaking about the various parts of the temporal bone. Here I'll just show the tympanic part of the temporal bone out of the 4 parts. Okay, and then here this is the squamous portion. This is zygomatic bone, and zygomatic bone, that is squamous. So this is the tympanic plate of the temporal bone. It makes a suture called tympanosquamous suture there, and then here anterior to the petromastoid bone, it forms tympanomastoid suture line. These are the 2 suture lines that tympanic part of the temporal bone makes with the squamous temporal bone and the petromastoid. Okay, so now this is, since this is a dry bone, so I'm directly going inside now. So now as you see here,
The right bone or left?
this is the right bone. Okay, this is the right temporal bone, zygomatic, squamous, mastoid, and then inside here is petrous bone, and then this is the tympanic part of the temporal bone. Okay, so now as we go inside, in live subjects or in the wet temporal bone, so we see the tympanic membrane, and the tympanic membrane, as you all know, has got the annulus, the fibrous annulus, which gets lodged onto the bony sulcus. You can see very clearly the bony sulcus. Okay, so this is the bony sulcus. This is absent near to the notch of Rivinus. This is notch of Rivinus. Is it all clear there? The picture? Yeah. This is the anterior tympanic notch, that is anterior tympanic spine of the notch of Rivinus. Here, the posterior tympanic notch, that is missing, drilled out. Okay. So once we elevate the flap, we enter into the middle ear. Okay. Once we enter into the middle ear, let us identify the structures. Okay. So now what are the structures? This is the promontory. This is the oval window. In life or in the wet temporal bone, we have got stapes sitting over there. This is the oval window, and this is the round window. Okay, this is the round.
Using 0 degree.
0 degree 4 millimeter endoscope, sir.
So there is no distortion of anatomy at all.
There is no distortion, sir.
Yeah.
Correct, sir. Correct.
Yeah, makes sense.
So now, can you see all this groove? Can you see this groove?
Yeah.
So this groove is formed by the glossopharyngeal nerve, that is Jacobson's nerve, tympanic branch of glossopharyngeal nerve, which forms tympanic plexus over the promontory and supplies the middle ear. Okay, and so that is Jacobson nerve. Now I'll come further. So these are the various, and this is hypotympanum. I'll start describing the structures one by one. Now, when we studied, there was a different division of the middle ear. Now, the endoscopic anatomy has given us new terminologies. Okay, so now the Jacobson nerve, anterior to it is protympanum, posterior to it is mesotympanum. Okay, so this is protympanum, mesotympanum, hypotympanum, and then epitympanum. Okay, so now what are the boundaries of the protympanum? Let us see. Posteriorly, as I said, this is Jacobson nerve, that is the posterior limit. Superiorly, see, this is actually drilled out. This is the canal for tensor tympani. The tensor tympani muscle takes its origin from the walls of the canal for tensor tympani. This is actually, there will be a bone. The bone has been removed. So that is the superior boundary. Okay. Inferiorly, there is protinaculum. So protinaculum is, here it is not that very clear, but approximately this is protinaculum. From the promontory, it goes, a ridge of bone goes to the anterior annulus. So anteriorly, it is the anterior annulus. You understood, no? Protympanum, superiorly, the canal for tensor tympani, Jacobson nerve, and this is a new terminology, that is protinaculum. Protinaculum, the bone from the promontory to the annulus, and then anteriorly it is the annulus itself, anterior annulus. So this is protinaculum.
You hear me?
Yes, sir.
Okay. And request delegates, in case there are questions, either they can ask directly or you can send a chit to the to us and we will answer. and one mic will be circulating to you.
Okay, so now see here actually see there will be sometimes spikes of bone, that is a bony covering the internal carotid artery, the carotid bulge. Sometimes it may air cells may be present, sometimes bony spicule may be present, sometimes it may be dehiscent also, but that is a rare thing. Okay, that is carotid eminence in the protympanum. Now coming to the hypotympanum. What are the boundaries of hypotympanum? Superiorly it is the promontory, and here anteriorly it is, I have told, protinaculum, inferiorly the annulus, and then posteriorly this is funiculus. Funiculus is again, can you all appreciate, this is a ridge of bone. This is a ridge of, sorry. Yeah, yeah, sometimes may be there, sometimes may not be there. Correct, sir, correct. So here actually it comes here from here, but here it is missing. So approximately you have to imagine, okay? And then this bulge is called jugular bulb. This bulge, it not just the, see, sometimes it may be dehiscent, sometimes it may come up to the round window. So when you're doing a myringotomy grommet insertion, you may end up in troublesome bleeding. Or when you are elevating the flap, if you're using sharp instruments, then also you can land in problem. Okay. So now in the mesotympanum, now let us come to the retrotympanum. So retrotympanum contains some various structures. So the first one to start in the retrotympanum is the oval window, which lodges the stapes footplate. Just let me go inside and then see if I can see. Can you all see the opening there?
Yeah.
Can you all see the opening?
Yes.
That.
Posteriorly.
Yeah, correct, sir, correct. So because yeah, here I'm having, it's clear now, sir. Yeah, now it is still clear. See, that is the opening of the posterior semicircular canal. That is the opening of posterior semicircular canal into the vestibule. Okay, so that is the one, and then so that is the oval window which lodges the.
The end of all I will be showing the vestibule and anatomy of the vestibule from mastoid trans labyrinthectomy. Okay, now Dr. Shankar is showing the same opening, that is the antulary end, isn't it?
Yes, sir. Yes. Posterior semicircular canal. Yeah, correct. So now superior to this is the horizontal portion of the facial nerve. This is the horizontal portion of the facial nerve. So it always forms the superior border of the oval window. So that is another important structure. Now as we come here, this is probably the pyramid. It is destroyed. So in life, this gives rise to the stapedius muscle, and the tendon comes and gets attached to the neck of the stapes. And then here we are supposed to see ponticulus. Okay, again here it is missing, probably it is broken. I cannot say missing, but it is broken. So ponticulus is from the pyramid to the promontory. That is a ridge of bone. So this is called ponticulus. Above the ponticulus is oval window, or also called as posterior sinus. And then below the ponticulus is sinus tympani area. See, this is so beautifully seen in endoscope, but actually in the microscope we have to remove a lot of bone to view this area. And this sinus tympani is important because any cholesteatoma or retraction pocket lodged here is difficult to remove microscopically unless until you remove a vast part of the bone. Whereas in endoscope, you insert an angled endoscope and then you can use curved suction or some scoop and then remove the retraction under vision. Okay, this sinus tympani can be shallow, it can be deep, or sometimes that is type A, type B, and then sometimes it can go below the vertical segment of the facial nerve. As you can see here, my this one is going. Can you all see? That is deep sinus tympani. So that is difficult to remove any cholesteatoma lodge there or the retraction pocket lodge there. Now, can you see this ridge of bone? This ridge of bone is from the superior lip of the round window to the posterior wall. So this is called subiculum. So sinus tympani, if anybody asks the boundaries, superiorly the ponticulus, inferiorly it is the subiculum. Okay, and this is the round window. This is the round window, the superior lip and the inferior lip. Okay, and then coming to the round window, here you all know that there is a round window niche membrane which helps in actually conduction of hearing. Okay, the sound vibration travels from the oval window and then it acts as a cushion, the round window membrane. That is how the electrical signals are generated. Okay, here if you see, there is a ridge of bone. This is a prominent bone within the base of the round window area, or this is also known as sinus subtympanicus. Okay, sinus tympani. This is sinus subtympanicus. So below the tympanicus. Okay, sinus subtympanicus. Yes, sir. Yes, correct. Because of the endoscopic anatomy and better visualization. So this prominent bone actually leads to the round window. Sometimes when we cannot identify the round window membrane, if we follow this here, usually we get the round window membrane. That is the landmark there. Okay. So now,
Tell what is operculum? They keep telling operculum in this area. Isn't it? Can you just tell us what is operculum?
operculum, sir.
Yeah, operculum of the round window. See, that is
Ah.
what you are saying.
This one, sir.
Prominent sometime hiding the round window.
Ha.
Operculum.
Ah.
And we have to remove the operculum during cochlear implantation in some cases.
For round window insertion. Insertion. Okay, sir. So that is one. And then we also know what is known as facial recess. Okay. So when Dr. Shreyas will be demonstrating that posterior tympanotomy approach, he'll be talking about this facial recess. Okay. So sinus tympani is different. Facial recess is different. The sinus tympani is medial and anterior to the facial nerve. Okay. Whereas the facial recess is, see, this is the horizontal portion, the vertical portion. This facial recess is posterior. As you see, posterior and lateral to the facial canal. Medial to the facial canal is sinus tympani. Lateral to the facial canal is facial recess area. So here. So actually he will be gaining from the mastoid. He'll be entering into this area for this posterior tympanotomy approach for this cochlear implantation. And also sometimes you can also do to clear sinus combined approach tympanoplasty. Also people do that approach. So this is where he is going to enter when he is going to demonstrate. So this is facial recess area. Okay, lateral and posterior to this vertical segment of the facial nerve. So that is over. Now coming to the epitympanum. Epitympanum is a space bound superiorly by, I'll just have a tilt. See, this epitympanum is not smooth. If you see, it is always rugged. Okay, it contains the head of the malleus, the incus, incudomalleolar joint. Okay, so that is the body of the incus. So now the roof is formed by the tegmen tympani. So where it separates a thin plate of bone, you can see the roof, no? So you can see the roof. So where it separates the epitympanum or the middle ear cavity from the middle cranial fossa. Okay, so that is one, and that is superior boundary. Inferior boundary is anteriorly the canal for tensor tympani, and then here the facial nerve, and then also in life we see few ligaments and then membranes. Okay, here there is tensor fold, and then here lateral incudomalleolar fold will come here. Okay, so that is a part of epitympanic diaphragm. Laterally it is bound by a part of the tympanic bone only, that is called scutum. Scutum. If we remove this bone, we can gain access into the epitympanum. So when we remove this bone either by curette or by the drill, so that is known as atticotomy or epitympanotomy. Okay, so if you remove this portion of the bone, you can gain access to the epitympanum. So this is, sir. Correct, sir. Correct. Scutum, yes, sir. No, it is the outer attic wall or the lateral attic wall, which forms a bone, and then below the epitympanum is covered by the membranous portion, that is pars flaccida. That is only a part of it, pars flaccida, but majority of it is formed by the outer attic wall or the lateral attic wall or the scutum. Cholesteatoma, correct, sir. And retraction pocket, correct. True, sir. True. Correct. So this is
here. There is a question,
sir.
What is the limit of the removal of scutum?
Sir, removal of scutum is up to the this one in flush with the tympanic this roof we can do, sir.
So it depends on the disease. If until you explore the extension of it, well, you can remove the whole scutum. Once you remove the whole scutum, then you will get the anterior buttons in the posterior. That's part of it. And in case you want to limit the removal of cholesteatoma, just you can do a limited removal of scutum, remove the cholesteatoma, and reconstruct the scutum by concave. I think those things can be discussed at the time of dissection.
Correct. And some of them also do what they do is they do a sharp cut of the bone and then replace back the same bone.
Yeah, because nowadays you are available with the electrode drills.
Correct.
And also there is one more, I'm not getting the name.
And then that is the eustachian tube area. Can you all see?
Yeah.
That is the yeah. That is the eustachian tube area.
Now we can repeat portion of the bone and we can replace the bone. For the workshop ends,
and then actually
Sorry to interrupt, because that was the question. Sometimes when we have an extensive cholestoma and a cavity, the whole sputum is already gone. So we can remove as much as sputum we want. I mean, basically to dissect the disease. And we said that the endo-ear dissection, the people use this harmonic scalpel. There is one harmonic piezoelectric device, piezoelectric device, which can be like it is very slow cutting, something like your curved knife. I mean, the probe is like your round knife with serrations. So you can use that to remove the bone. But it is slow and under irrigation. It's just a costly device, but might be useful for those who do endo ear.
it is not that costly when compared to other devices. It is costing only 1.5 lakh. That's all. I was also surprised.
I have done using this.
But again, different models are available. Probably based on that, the cost can also vary. But the basic equipment is quite cheap, quite affordable.
The Europe, I saw it in the Euros, I did not in India.
So
one more question for the question the audience was asking. Once the attic is eroded, your decision for to be very, very planned and careful. Whether you want to remove the complete attic or you want to do a open cavity mastoid as an extension of that. So, but if you are doing the limited atticotomy, you clear the disease and construct the no hidden area of the trauma. To reconstruct or leave it is a question. To leave it again, patient will have persistent problems. So better to reconstruct the attic what you have taken out. But to clear the disease first is our mottos and probably extend the atticotomy to modify the attic. I can avoid them. Dr. Shreyas, there is some sound disturbance, some screeching sound. Probably somewhere the mic is.
We are looking into it. Sagar.
You can go ahead.
So I think the last portion of I wanted to show you is endoscopically. See, as you all know, this is the horizontal portion of the facial nerve. And then can anybody tell what is this? I want the delegates to answer. Some interaction. What is this?
They are saying it's the dome of the lateral semicircular canal.
Correct. So dome of the lateral semicircular canal. When Dr. Shreyas is demonstrating, two things you have to observe. One is change in the sound of the burr. And then also, if you see the color here and color here, different. So this is almost ivory white, something different. If it is brown, this is a bit more whiter. So this looks more, this is also not fully ivory white, but so change in the color and change in the, this is the dome of the lateral semicircular canal. Always lies superior and then posterior to the horizontal facial nerve. So it's a very, very constant landmark. So this is all. In fact, when you're doing endoscopic surgery for cholesteatoma, you can go up to here. Remove the scutum, you can clear cholesteatoma up to the lateral semicircular canal easily. But beyond that, I think we may require microscope. Thank you, sir. Yes.
I think we can see the other structures like tubular activity, Mike's dot, all these things. Have you tried any time?
I have not tried, sir, but today we can try. Yeah, so we could see the opening of posterior semicircular canal. That was actually good. I did not expect it. I just tried to pass. Whether we can see, we could see. Yes, sir.
And we are getting a good three-dimensional anatomy.
The technology has really helped. Otherwise, sir, when we were students, I mean, you are still 5 years senior to me. We were only imagining. So what we used to be taught, even in the textbooks, was middle ear cavity is a matchbox. So people who used to smoke used to remember it very well. 6 walls, anterior, posterior, superior, But we always used to imagine. It was only imagination. And then the line diagrams can never give you a picture like a three-dimensional anatomy. So the present generation is very lucky. So they are even at MBBS level also, they are far more knowledgeable, and as PGs definitely more knowledgeable than our generation.
That's what I said. I told in the opening speech that the only thing which can score over you is that they are more experienced because you are born early. That's all.
Correct, sir.
The rest all, the ball is in their court. We can learn from them, isn't it?
Correct, sir. Sir, we are just waiting for the 2.7 millimeter endoscope.
That was the last this thing, and then you will start the procedure.
Yes, sir. Until then, any discussion, anything is welcome. And then just from the delegates, I want to ask 2 muscles and 2 arteries in the middle ear cavity.
Yeah, Shankar.
Sir.
There's a question from delegate. With the endoscope, can you see the crotch, jugulo-carotid septum? Notch. That is, it is called a notch.
That's true.
Not crotch.
Sir.
There is the jugulo-carotid septum, which is the first one to get eroded in glomus jugulaire. Can you identify that through an endoscope? So,
see, it all depends upon the aeration of the hypotympanum, sir.
Yeah.
So if it is very well aerated, we can't see. If it is fully if there is no aeration, I think we can see. I do not have any experience of seeing. Cog we can see, sir. Yeah. Cog we can see. I'll show you here. I'll show you.
You mentioned it, no?
Correct. Cog I'll show, sir. Till the time that comes, cog, yeah. So that cog can be seen very clear.
Can I add on the crotch, sir?
Yeah.
The crotch is actually between the jugular and the carotid artery, petrous. That is actually developed when you drill. That's it's a jugulocarotid spine, or what you call as a crotch. It is basically a ledge of bone that it appears in between as you want. That can only be done now. Maybe tomorrow you can.
Now it is in the attic, sir. Asked, see approximately, see what is COG. Actually, COG stands for center of gravity. Okay, so it is a bone from the suspended from the tegment tympani downwards towards the processus cochleariformis. So this is approximately the area of processus cochleariformis. Okay, that processus cochleariformis is a bone, ridge of bone from the canal which turns perpendicular and laterally from the canal for tensor tympani, through which the tendon of tensor tympani exits and gets attached to the neck of the malleus. So approximately, if you take this as the area of say processus cochleariformis, and then if you draw a vertical line, can you see, sir, this probably that ridge of bone suspending from the tegment towards the processus cochleariformis.
And it divides the epitympanum
Anterior and posterior. Correct, sir. Correct. And then processus cochleariformis, another landmark is just superior to it is the geniculate ganglion. That is the landmark. The moment we break or we drill out that processus cochleariformis, then that area is geniculate ganglion. If we remove that part of the bone, we can see the geniculate ganglion, and anteriorly see approximately here that area for this one greater superficial petrosal nerve, GSP. Yeah.
Okay, 2.7.
Sir,
2.7.
2.7 we have got, sir.
Go through the whole.
Yes, sir. I'll go.
Expert, you want to use 2.7 or 4 mm?
Anything is okay. Yeah, 2.7 is also okay. It's clear now, sir?
Yeah. You can find those. Yeah, it's better. Yeah.
Okay, sir?
Yeah, it's better. I know it's difficult, but it's just an attempt.
Correct. I think we have to drill out the bone, sir.
Yeah,
then only we can. Otherwise, this is.
understand.
Yeah. Otherwise,
But,
this. Yeah.
Again, we can see the ampullary end of the process.
Yes, sir. Yes, sir.
Only thing is, if possible, no, we probably thinner scopes like 1.8 different scopes are also available. Very thin.
Or we can also try flexible, sir. Flexible
Yeah.
endoscopes.
Endoscopes. Probably we can see the cochlear aqueduct below.
Yes, sir.
We can see the vestibular aqueduct.
Yes.
And it will become much more clear.
Correct. Correct.
Okay. Maybe we will introduce that in the next one. Okay,
Then,
I think you can start procedures.
yeah. Yes, sir. So now we are going on to the wet temporal bone. See the same, because as Dr. Pradeep said, whenever wet temporal bone is available, then only he is going to announce the workshop. So that shows the seriousness of the situation. That shows that how much scarcity the wet temporal bone is. So that is why what we are going to do is, we are since the same temporal bone, wet temporal bone, is going to be shared by me, Dr. Shreyas, and Dr. Pradeep. So what I am going to do is only so that we will not do the procedures which will come in the way of others.
Correct.
Sir.
With one temporal bone only, all the fractal members are going.
Correct. Yeah. So this is the, I think dust is there. Can I?
Impassioned looks in the wet temporal bones.
So can I suction? Sir, I'll just do suction and see.
Yeah.
Or
Yeah.
I'll just try to.
Dissection.
Goat bone. Okay. Goat bone. Goat temporal bone we have not used. Goat head we have used for endoscopic sinuses. But I don't know how
Wash
ವಾಶ್ ಮಾಡಬೇಡ.
Human temporal bone.
Okay.
Is there any literature on that? You can throw some light on that.
I'm just trying to clear the TM.
Get some experience with the whole temporal bone. So whatever it is. You have tried.
ಸ್ವಲ್ಪ clean ಮಾಡಿ, clean.
Okay, that is quite.
Suction, suction.
Yeah, liberating and all that. And that anatomy is not same as different parameters like anatomy. But for vaccine
Can I
purposes,
give a watch there?
Please. Here we are just trying to clean the debris, sir, on the TM. Yeah.
what we can do is, there are 3D temporal bones that we have. So I think 3D temporal bones are very much very temperature. So 3D temporal bones are available and one can start practicing on 3D temporal bones.
Better ಅನ್ಸುತ್ತಲ್ಲ? Definitely better.
Maybe one more watch.
Ah.
It's available. I have the contact number.
Yeah. Good. ಸಾಕಾಯ್ತು. Sir,
Approximately cost 8 to 10,000.
good. Sir, we cleaned the TM, the debris. I think it is but much better, sir, now.
Yeah.
Okay. So now what the initial procedure I am going to show is this intratympanic steroid injection. So can any of the delegates tell the indication for intratympanic steroid injection?
Yeah, they're saying it's sudden sensory neural hearing loss.
Yes, sudden sensory neural hearing loss. Next,
They're saying Meniere's disease.
Meniere's disease, correct. And sometimes acoustic trauma also.
Yeah.
So,
Acoustic trauma that is leading to sensory neural hearing.
correct. So now, if you see here, probably this is the hand of malleus, and then this is the roughly the area of the incudostapetal joint or the oval window. So just inferior and posterior is the area of the round window. So the idea of intratympanic injection is to inject steroid directly into the oval window area, hoping that the steroid diffuses through the round window membrane, that semi-permeable round window membrane.
Correct.
Semi-permeable round window membrane, and then reaches the cochlea, where the idiopathic sensory neural hearing loss, sudden sensory neural hearing loss, probably idiopathic. There is a hypothesis that lot of inflammatory mediators are going on in the perilymph area. So through the round window membrane, the steroid gets absorbed and then seeks a higher concentration in the perilymph than when we inject IV prednisolone or even the oral steroid. The concentration is much higher because there is a blood perilymph barrier. So the amount of steroid reaching the perilymph may be less, actually less, around 30% less. And then also the steroid undergoes first metabolism in the liver. So this is one of the alternatives, or some people use it as the main weapon for sudden sensory neural hearing loss. We inject this either dexamethasone or methylprednisolone. Okay, so I usually use dexamethasone. Sir, what do you use, sir?
We use dexamethasone.
Dexamethasone. So
other drugs which can be injected intratympanically.
what, sir? Gentamicin also can be injected. That is for vertigo. That is
Any other you have got experience? Any other drug which you have injected?
no, sir. Only steroids, sir. Only.
With BRP injection. That is platelet
Zoom the image, sir.
Yeah.
Okay. Here again, when all other types of drugs fail, then at the last resort, we can give PRP injection, platelet rich plasma. In fact, we have a long series. We have started doing this in 1 year.
Oh,
So the patient's blood is drawn and it is separated by centrifuge into white portion and the red portion. The white portion, that is the plasma, it again forms 3 layers: upper, middle, and lower layer. Is the lower layer which contains the maximum concentration of platelets, and this is drawn, and this can be injected. Weekly 1 injection to 6 injections. And again, the indications are like idiopathic tinnitus and sudden sensory neural hearing loss, which is not improving with medications, and also medias disease. So a lot of indications are coming out, but prognosis is equal. Still, it is not evidence based. Still, a lot of papers, but a lot of papers are coming out, and we have given more than 100 injections.
Oh. Oh, very nice, sir.
We are offering this treatment, PRP.
PRP, okay.
And this PRP, the platelet has biological activators.
Ah.
These are protein activators, and these protein activators are supposed to stimulate the synapses and the neurons which are reversibly damaged.
Ah.
They can reverse. Irreversibly damaged neurons will not work. So it depends on the duration of the lot of indications, like duration of hearing loss, cause of hearing loss, cause of tinnitus. So we can always give the prognosis, tell the prognosis to the patient, and offer this PRP injection. And this can be injected in time.
Okay, sir. So roughly into the area of the
50-50, I can say. So some people who are using hearing aid with partial benefit, where they are not having speech discrimination, have given this, and they are now saying with hearing aid discrimination scores have improved. And some sudden sensory neural loss have improved, acoustic trauma, and recently one patient with fallen bounce. That patient in ITD elsewhere, it had not improved, so they came to us, and they were not willing for hearing aid, and we gave PRP, and those patients.
so results are good, sir?
Yeah, results are equal. At this stage, I can only say results are equal.
Ah. Okay. So this is
0.5 ml only. Cochlear contains only 0.5 ml.
correct. 0.2 to 0.4. Yeah, we can inject. Correct.
One more thing.
Sir.
Before injecting, no, you want to make one window.
Sir,
escape, isn't it?
Yeah. Yeah. So that we can make, sir. If the pressure is too much and if the patient is complaining of vertigo, we can make one escape window. We can make an escape window. We can make, or if the patient is comfortable, we need not make.
Okay.
So if we have to give repeated injection, it's a good idea to insert a tympano, this ventilation tube, and then Grommet, and then also inject. So here I am just penetrating the. Can you see? I went into the middle ear. Inject matra.
Yes.
So now. Block agide.
Shankar, I have seen, if you don't make the escape window,
sir.
then once you inject, and withdraw the needle like a fountain.
It will come. Yes, sir. Yes, sir.
See, make a window, escape window, and also tell the patient to keep swallowing while you are injecting. Then the reverse fountain, it comes, but it is less force.
Less. But actually, the recommended thing, sir, is not to swallow for at least 10 to 15 minutes, or yawn, or talk, or because we want the medicine to be there in the round window area, so that maximum medicine can get into the.
At the time of injecting, not after.
Okay.
Time of injecting, we want the air to escape.
Escape.
Feeling something, the air should be clear as to escape. Like the insertion tube or to the escape window.
Correct. So here you saw injection of this, and then some of them it came out also. That is intratympanic injection. Yeah. So now we'll going to the second exercise, that is myringotomy with Grommet. So here we are using myringotomy knife only. So this is the umbo. This is the umbo, and then exactly the landmark is just inferior to the umbo, or that is the starting point. Go antero-inferiorly, penetrate.
Shankar, I also see if the radial incision what you are giving.
Sir.
Okay. So that will become more straightened after the glue comes out.
Correct, sir.
Better to give first a vertical incision. Okay. From umbo to dictochrome, you give a vertical incision. Once the glue comes out, automatically the tympanic membrane slightly retracts, and the incision, the vertical incision becomes radial.
Radial.
And then it is easy for you
Correct.
to insert
True, sir. True.
if it is horizontally directed incision, then to insert a Grommet will be difficult.
Correct, sir. Correct.
You have experienced that?
Yes, sir. But yeah. But since I am doing only through endoscope, I am not finding any difficulty.
Okay.
So, however anterior it is, so now just insert it at an angle and then just gently ease it out. You can
Still you are able to do it.
Yes.
And this is, I think, one of the most finest procedures.
Finest. I remember Dr. Pradeep Kumar telling, if you can do Grommet insertion, you can do tympanoplasty.
I also was telling, when you want to check a microscope, how good it is, you insert a Grommet in the microscope. If you can insert Grommet, you can do all of it.
So, yeah, the second.
I want to ask you,
Sir.
you have chosen anterior quadrant.
Correct.
Is there any scientific reason?
Sir, the scientific reason is, one is it is nearer to the eustachian tube area. So, in fact, I also call this as, one of the lectures, I call this as a bypass surgery, sir, just to have a glamour, because why only cardiothoracic surgeon should have the glamour. So, I introduce this terminology as this is a bypass surgery. I don't call it as myringotomy Grommet. So then they are asking, are you doing a bypass surgery for the ear? Yes, I am bypassing the eustachian tube for ventilation. So that is why this is also called ventilation tube. So because the eustachian tube is blocked, even if you do adenoidectomy, it may take around 3 to 6 months for the eustachian tube to gain its function. So that is why we are inserting the ventilation tube. Otherwise, once the glue is gone, there is no need of ventilation tube. So this ventilation tube is basically the air from the external ear is getting into the middle ear, and then that is how it is getting ventilated, and through the normal ventilation pathway, it is reaching the attic and the mastoid. So that is one reason why we are inserting into the anterior-inferior quadrant near to the eustachian tube area, because it stimulates the normal air pathway. Second is, there are no important structures in the anterior-inferior quadrant. That is another thing. See, if we insert into the posterior superior, we can't, because there is incudostapedial joint. And then posterior inferior, sometimes if the jugular bulb is dehiscent and if it is a bit superior, then there is a risk. So that is why anterior-inferior quadrant. The third reason is the epithelial migration is the slowest in this quadrant area, out of the entire area of the tympanic membrane. So that is why the Grommet will stay for a longer time. See, if you gradually see over a period of time, when we insert the Grommet, it extrudes by coming to the posterior quadrant. That is because of the epithelial migration. Finally, it gets extruded. So when we insert here, it stays for a bit longer time than when we insert it.
After inserting Grommet,
Sir.
the patient
Ah.
we would have seen that Grommet is the posterior quadrant.
Correct. And we'll be telling that other surgeon has because we are inexperienced beginners. As beginners, we used to think the other person has not done a right job.
In fact, the studies have shown the slowest migratory ability of epithelium is in the anterior superior quadrant.
Correct, sir. Correct, sir. True. Correct.
Next anatomical part is the anterior inferior.
Correct, sir. Correct. True. 100%. Correct.
So the next procedure that if he wants to have the Grommet for a longer time, then there is something called micro-tube.
Correct. So that
micro-tube, I think Shreyas is ready.
Dr. Shreyas is going to demonstrate that.
Micro-tube.
Yes, sir. Yes. I am going to give to Dr. Shreyas now.
So any questions? Yes. Sorry to this constant. Maybe little bit on the supra area.
Doctor.
I'll use the other mics. No
Oh,
problem.
okay.
Sir said, migratory is lower than active superior. Sometimes I want the Grommet to stay for longer time.
Sir, it got that.
And sometimes I reverse
Mic matter like that.
the direction. So I reverse it and then I look at it. Sometimes we see the reverse with the broader end and
just adequate. I do that, but definitely.
ಇಟ್ಕೋಬೇಕಾಗತ್ತೆ ನಾನು ಇನ್ಸರ್ಟ್ ಮಾಡುವಾಗ ಹಲೋ 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 can you hear me?
Not lost it, but sometimes yes, it has gone inside because when we don't have a sharp single knife, so first is
So I'll remove the Grommet, sir.
single knife or instrument which you
I'll
use.
remove the Grommet, sir.
So if it is very blunt and you tend to extend the incision and you tear it, you can lose it. Then I use the suction. Use the micro suction to gently pick up. That is the what happened. One of my colleagues inadvertently pushed things into the nuclear, and she just warned me. Okay, she was worried. Then I said, nothing to worry, don't fish it out. Something as Dr. Ray said, you can carefully fish it out because it was a can. If it is completely lost, why not worry?
You never remove a Grommet, sir. ಅದೇ ತರ ತೆಗಿಬೇಕು.
Correct.
You need not fish it out. By doing fishing it out, you tear the tympanum more and more. And you cannot put the drum. Like Grommet, you want to use that out. You cannot use that again. That gets one. So instead, you put a fish bone. You do whatever.
ಇದು ಓಪನ್ ಇದೆ ಅಲ್ಲ?
Yeah. Yeah.
Good morning, everyone. Can you all hear me?
Yeah.
Yes, this is Dr. Shreyas. I'm actually
Wait, Dr. Shreyas.
yes.
After how many days of medical treatment, you will indicate what is happening. Grommet insertion, like if patient has Cochlear, you can straight away advise them for the it's a surgical condition. Cochlear surgical condition. The day you diagnose Cochlear, you have to tell them when you want to do. What you are saying is for violated media with effusion. No, not for Cochlear. The diagnosis of Cochlear is surgical. What you are telling is the violated media with effusion. If it is not naturally about Cochlear. Effusion is there. You can tell the patient go for lipolysis, go for antihistamines and other things. Right?
ಚೆನ್ನಾಗಿ ಬರ್ತಾ ಇದೆ ಸರ್.
Then you know that you can break. If there is no air bubble formation, then the fluid is getting turned into stratum. Then you can. There is nothing like time. Depends on the patient's symptoms and your finding.
Sir, just
No, by 12 weeks you could have described the mechanism of the ossicular change. There's nothing like time. 12 weeks. 11 weeks you should not do. 12 weeks you can do. That is not time.
Yeah.
Yeah.
Sir, there is actually what the delegate is asking. I mean, there is a criteria. That is what he is talking. So usually 8 to 12 weeks is the normal time for the any middle ear effusion to resolve. So, but as Dr. Pradeep sir rightly said, see, we can wait because some patients they think doctor is just indicate advising surgery, but heart in heart we know that it will never resolve. The moment it is thick and gum-like structure, it can never ever resolve.
In fact, with suction tube also it is so difficult sometimes to extract that fluid.
But yes, there is a criteria. One is 8 to 12 weeks. Second is if the AB bone gap, that is ear bone gap, is more than 30 decibel, or the conductive loss is more than 30 decibels up to 50 decibel, we can insert. We need not wait. That is another criteria.
Okay. Hello. So shall we proceed? Yes, sir. So actually, Shankar sir has very nicely demonstrated the insertion of the grommet, which is actually a difficult procedure. But one of the first procedures which needs to be tried with an endoscope before somebody ventures into doing an endoscopic tympanoplasty or endoscopic stapedotomy, probably.
Yeah.
So this is the way to start any endoscopic journey, I would say. So we've all come across cases where sometimes the grommet needs to be inserted repeatedly, or in a patient who has had repeated infections, sometimes it could be a retraction pocket which is developing.
So in these cases, we may want, or maybe a systemic disease also, something like cystic fibrosis. Yes. So that is some time when we are indicated and we need to leave a grommet for a longer time. Typically, these grommets get extruded within maybe about, it depends on the design, but maybe about 3 months, maximum 6 months. Sometimes you've seen it stay for a little longer time, but typically not more than that. So if we want this grommet or a ventilation tube in place for a longer time, maybe say 2 years, 3 years, or we may need it permanently there, then we can use something called as a micro T tube. So this is a micro T tube. I hope you can all see it. It has 2 flanges and a vertical tube which will actually ventilate and provide air supply to the middle ear. I can show you forceps kodi. It's a very soft tube. Unlike the grommet, it's not a very hard thing. So even if I hold with my micro forceps, you can see it is actually collapsible. Okay, and micro T tube will have space for ventilation, but it is not enough for the tympanic membrane to actually collapse this tube and close off the aperture. So what we'll do, introduction of this micro T tube is actually a difficult thing. So you can see that there are 2 flanges. You must all be wondering how will these 2 flanges enter through the middle ear, if at all we have to insert. So previously, people have tried many things. I can show you. Let me just pick up. Can somebody hold the endoscope for me?
Previously, people used to hold it with the microprime forces and insert it. Inadvertently, it used to cause tympanic membrane gag. That's why the T2 plunger was designed.
So people were actually folding the flanges like this earlier and trying to insert through the opening they've created, and
Louder.
through the opening they would actually fold the 2 flanges, and they would try to push it through the myringotomy opening they had made. But this was a very difficult step, and lot of times, like sir said, it would cause tears of the tympanic membrane. So in the process of insertion was a very difficult thing. So Pradeep sir has actually designed something called as a micro T tube inserter. Yeah, plunger. And this plunger is actually very useful, and I'll demonstrate to you how we use it. Maybe this thing, is it okay? Kanata sir, idralli? Okay. So this is a T tube plunger. Open ಮಾಡಿದ್ರೆ better ಅನ್ಸುತ್ತೆ. Light ಹಾಕಿ. Because it's very small, we're just trying to, or microscope na adjust ಮಾಡಿಲ್ಲ sir. Yeah. Okay. Yes. So there is a opening in the T tube plunger. What we will do is, yes, insert the micro T tube into the plunger. 26 gauge needle. There's a small 26 needle. 26 needle. ಅಲ್ಲೇ ಇದೆ ಅಲ್ಲ ಇದ್ರ ಜೊತೆ. Okay, so we can use a 26 gauge needle, and there is a small slot here. We can hold in the center of the micro T tube and put gentle pressure. The micro T tube gets into the system, into the plunger. Then you can remove the 26 gauge needle. So there is a mechanism here. So just like our micro forceps, if I press, then the micro T tube will actually come out and it will get pushed into the middle ear. So the same thing, I will reinsert and reload my micro T tube. Okay. Now we'll use the endoscope. Now it is loaded and ready to be used. Thank you, sir.
So this needs a regular pericardial incision, like Grommet.
Yes, sir. Yes, sir. The incision is also already made. So
I think you have to widen the incision a little bit.
yes, sir. I will just see that.
But I particularly think little more incision is necessary for the
T-tube insertion.
and the regular.
So laryngectomy now.
And one advantage of this T-tube is that it will stay for longer time, and it is supposed to be permanent. It will never get extruded. And in case in future it wants to remove, you have to remove it. Okay.
So this is the thank you.
Yeah.
This is the opening.
Because tympanic membrane is brittle.
Yeah, tympanic membrane is very brittle here. So through the same this thing opening, we will insert the T-tubes.
Yeah.
Plunger. So we can. This is the T-tube with the T-tube plunger with the T-tube loaded. We just have to go till the entrance. Yes, we have to go slightly inside and start pressing. So the T-tube will go inside and open the flanges. After that, it is important to stabilize the T-tube and at the same time keep pushing and removing the T-tube plunger. You have to
Shortness of the tympanic membrane will increase.
yes.
So actually, this instrument revolutionized the insertion of microchip.
So
Earlier it is very difficult, and so many children whom I have inserted earlier, and they all become adolescents, and the T-tube something like that.
Yes.
When I tell them when they go for swim, if they want to go for swim, then tell them they are going to swim. The only thing is removal is with wedding on the knee and then
So if at all you require, if you feel this is too long, you could cut it off and maybe leave it. So children are quite happy, and it will not come in their way of routine work. So this is something. This is an option for having a ventilation pathway for a little longer time.
okay, nicely done.
Thank you, sir. Over to Shankar, sir.
Yeah, there's a question checker.
Sir.
It doesn't get extruded.
Yes, sir.
And what will you do?
Sir, yeah, so far one patient had come, inserted the Grommet insertion done by another surgeon.
Yeah.
So till 2 years, the Grommet had not got extruded. See, I usually what I advise them is the nature keeps it as long as it wants. See, so in some people it gets extruded in 3 months only.
You remove the T-tube.
Yes.
Extra care.
No.
Not much, isn't it?
Not much. It's a very
So only in that case, and the patient was very insisting that the Grommet had to be removed. I have removed, sir. Otherwise, only in one case.
So after remove the Grommet, the consistent operation will be there.
See, because it was long standing, the perforation was there, but luckily the perforation got healed after 3 months, sir. Actually, there was a perforation, but since there was no infection, repeated infection, and the nature took care of it.
And what about blocked Grommet? In case there is a blockage of Grommet,
Yeah.
how to prevent blockage? First thing, second thing, in case it's a blockage, what will you do?
So I usually flush it, sir. Actually, I usually try to flush through that Grommet and then try to release the block. Sir? No. So many times it is not possible. And at the time of insertion only, what sometimes I do, if the glue is very thick and if I think it is going to get blocked, so I irrigate the middle ear with ofloxacin solution, and then also try to insert a small suction through the Grommet, repeatedly suck it so that the glue does not block. Otherwise, if crusting and all happens, it is difficult. And if it is not causing any problem, we can leave it alone.
Yeah, one thing, Shankar, what I've seen is grommets get blocked because of incomplete removal of glue. at the time of
Glue.
primary surgery. So primary surgery, as soon as the thick secretion, once we remove the glue, immediately we leave the not do that.
Correct.
You have to wait for few more minutes or seconds, and the glue from the mastoid will actually enter into the miliary if it is there. That collects, and then again you have to suck it out. Okay, so like they are repeated sucking out, and then you see the good miliary cavity and everything. That is to prevent. In case of all these efforts, if still the grommet gets blocked, then you see the tympanic membrane of the miliary.
Circular knife
If
or
there is
flat
no
knife?
glue, then you can leave the grommet. In case there is accumulation of glue because of block grommet, you can put the block grommet and the glue will come. And that's it's like vanilla. And the perforation, whatever you have created. So block grommet can be removed if there is recurrence of. Otherwise, you can leave it. And the block grommet will extrude as.
Sir, we have time now, sir. Shall I elevate the flap?
Now we are.
We have time, no?
We have got time.
Yeah.
Another half an hour, I think you can.
Okay. So now I'm going to elevate the tympanomeatal flap as we do it in tympanoplasty. This is endoscopic tympanoplasty is what I'm showing. So
Okay.
this is the annulus.
Yeah.
This is 12 o'clock, 6 o'clock, that is 3 o'clock, and this is 9 o'clock. So that is the orientation. So I take an incision just around 5 millimeters approximately. It is by just visual measurement, and then give a horizontal cut. Horizontal cut. And then usually I go up to 6 o'clock. And then here, can you see, sir? Is it visible?
Yeah.
See here, I am going beyond 12 o'clock up to almost 3 o'clock. So this is usually my incision.
But the 12 o'clock and 6 o'clock, the better visualize the endoscope.
Ah, yes, sir. True. True. See here, even without rotating or tilting the head of the patient, I am just giving incision. So now I am trying to elevate.
Bone center.
Yes, sir. I am trying to elevate the flap.
So near the
So you are using the regular instruments or any special instruments?
Sir, I use earlier I used to use regular instruments only. Now since almost now 5 years, I am using only this Panetis instruments, which has got suction as well as the.
In fact, Dr. Shankar, Panetti instruments are available with Indian surgical companies now.
Oh, is it, sir?
Yeah.
Yeah.
That the 6 o'clock area. See that you have not tapered it off.
I'll taper.
the
Yeah, correct. So that is just to extend the incision in case I need. So I can extend it later on also. Okay. Yeah, we can taper. Correct.
So what delegates will be starting is not through endoscopic procedures. They will be straight away starting with microscopic procedure. With microscope, you put incisions like this because we don't have endoscopes for all the stations. That is the reason. And we don't have monitors for all the things. So instead, you see the endoscopic procedure Shankar is doing, but you do the same procedure under microscope. Okay.
See, did you all appreciate this tympanomastoid suture line?
Yeah.
So that sometimes tear can happen if it is very prominent.
In fact, the prominent suture lines are circumvented by endoscopic routes.
Yes, sir.
Endoscopic routes, they become really obstacles.
Correct.
In endoscopic routes, it is hardly a matter, isn't it?
Correct, sir.
So Shankar, there is a question. What about the hemostasis? Endoscopic route, where there is that hemostasis is a challenge?
No, not at all, sir. If you give right infiltration and especially with now Panetis instrument, there is no problem at all.
There is a suction also.
Yes. Yes.
The key is vasoconstrictor. You have to use adequate amount of adrenaline.
Correct. And right plane infiltration. So this you can see the tymphanosquamous suture line.
So are you using endoscopic holder? The question was very
No, sir. No, I never use endoscopic holder. And see,
Umar Khan has endoscopic holder.
uh,
But not like again a few people have started using it. But some otologists, endoscopic otologists are using 4 mm scope holding in the hand and they're doing.
sir, in fact, the very fact that endoscopic ear surgery has come because you need not carry microscope wherever you go.
Okay.
See, now this endoscopic holder, again you require a microscope to get it attached. So then what is the advantage of they say two-hand technique. See, we are doing first with one-hand technique. So I am not very convinced with that logic at all.
In fact, Shankar,
Sir.
how we developed our endoscopic techniques were like every year we go to Arunachal Pradesh for camps. Isn't it?
Yes,
so there suddenly the microscope once we had a problem with my microscope and we had to finish the case.
Correct.
So that's how
Clean my.
like, necessity is the mother of invention.
Yes, sir. And
that's how we started endoscopy. Now way back probably 15 years back we started.
Correct. Correct. And then
before it was possible.
Correct, sir.
So want to enter what Shankar sir said because the adding endoscope to microscope. For me, I believe I am the old microscopic kind of approach. Wide approach also. The whole idea of doing endoscopic thing, what I spent some time in percutaneous mastoidectomy. Then if you're holding one hand and if you're moving the endoscope, it's a dynamic. So you want to move the hand. That is the whole idea. So you want to fix it to the microscope.
Yeah.
I don't know about that.
No, absolutely. It is Dr. Nikhil, no?
Dr. Udayban.
But somehow I think most everything can be done and it is very good. And I find the role of it combined approach or maybe you are
ಎಕ್ಸಸೈಸ್ ಮಾಡ್ಬಿಡ್ಬೋದು ಸರ್ ಎಲಿವೇಟ್ ಮಾಡ್ಬಿಟ್ಟು ಅದಕ್ಕೆ ಎಕ್ಸಸೈಸ್ ಇಲ್ಲ ಅಂದ್ರೆ ಇಟ್ ಮೇ ನಾಟ್ ಟ್ರೈ ಮಾಡಿ ನೋಡಿ.
No, correct. What Dr. Udaybanu said is correct. See, with this endoscope, you get unlimited illumination, unlimited magnification. See, now I am here, magnification is different. I am moving inside, the magnification is different. The illumination.
They say endoscope provide infinite magnification.
Correct, sir. And then here I have elevated the flap. This is the chorda tympani nerve.
Yeah.
Chorda tympani nerve. So I am trying to release it from the notch of Ribinus.
But whatever said and done, today patients are asking for endoscope.
Yes, sir.
Okay, when you say you are going to cut post-oral, they say why can't you do in front side? So it is becoming a challenge now. So what I feel is you should start doing endoscopy.
And then, sir, many.
And we can always tell the patient that this is more, it is not doing it. But when it is left and it is available to endoscope, I think you have to do. We have to offer treatment to them. Just because we don't know how to do, we cannot. That is not an excellent. We should learn.
So I'm trying to elevate it from the handle of malleus. See, because the tympanic. See, can you see?
Yeah, we can see.
That is the lateral process of the malleus. And then, see, because people are going to various nursing homes, see, they don't have microscope, they don't invest in microscope. And then, but definitely they will have invested in the laparoscopic camera because they were doing laparoscopic cholecystectomy and all. What you need to carry is just 4 mm endoscope and your instruments, that's all. See, the camera is there, the monitor is there, everything is there. So, easy for you to operate as well.
Shankar, there's one more question here.
Sir.
Is there something called 1-point infiltration? We are giving 4-point infiltration, isn't it?
Yes, sir.
But there's a question from delegate. Is there any vote for 1-point infiltration? I don't know, but have you got any experience?
No, sir. I always give all the quadrants, sir. I don't have any experience. Anybody else, I don't know. But see, the thing is, if we give all around, the hemostasis is better.
The analogy what you are telling, doctor, is just like a steptoplast. You infiltrate that one area, you can elevate the flap through the entire length. But in the ear, though you infiltrate, I think the distribution of the your xylocaine or saline may not be very prominently get elevated. And but the hypostasis is the key in endoscopic ear surgery. So if you are conversant with your technique and your mastered it, getting the good hemostasis in 1 point elevation, fair enough. There is no harm in doing 2, 3 points. Only caution is not to develop a hematoma when you are doing multiple infiltration. The blebs, what it forms, it will delay your surgery. You have to see that it gets settled, then only you can proceed further.
See, I've elevated the handle of malleus. I've made, yeah, skeletonizing, yeah.
You have done a wonderful job.
So that is, and here I'm elevating it from the flagna. See, I'm elevating from the bony annulus, bony sulcus. As I showed in the dry bone, see now the this fibrous annulus is lodged. Can you see? I'm dislodging it. Is just like, see if you yeah, if you see, I don't know, in earlier days when we used to ride bicycle, he removes the tube from the tire, that rim. So it is something similar to that. So we are just dislodging it, elevating it. Okay, so this is
Anatomy.
yeah.
Underlay technique.
Yeah, underlay technique, because I'm elevating the mucosa as well below the. See, can you all see that the groove?
The 3 layers of the tympanic membrane are
Elevated. See, this is the bony sulcus.
Viable in this case, then some tears. Otherwise, it is nicely done.
Yes, sir. So, in fact, Dr. Shreyas was suggesting me to remove the tympanic membrane. I thought, let us.
All temporal workshops, the first step they do is to remove the tympanic membrane and then go to the
Yeah. Yeah. So, just I'm trying to stimulate. So, what we do is, after doing this, I anchor it to the anterior wall, the flaps. Okay, here it is not sitting. Yeah, I'll cut it off. Scissor.
Coming to advantages of microscopic and microscopic and endoscopic. Another thing is in microscopic surgery, you are actually inserting some normal tissues and then entering into the area of interest. That is, it is called funneling. Funneling text. That is, you are separating it. Approximately there are but endoscope is tunneling text. Here, actually, normal structures are not at all disturbed, like only the structures of interest are available. What is funneling? So the primary healing is better.
Iris is
eyepiece sac concept.
Very post operatively next.
Sac alva.
Like and here microscope is as intended fixed magnetically. Here microscope is and illumination
Microscope.
and then depends on the experience. Shankar, there is a question.
Sir.
The bigger the population, is it difficult for endoscopic procedure?
Not at all, sir. Not at all. Not at all, sir.
The size of population is not doesn't matter.
The size of the perforation does not matter once you elevate the flap. In fact, I do all the things, whatever is done in microscopic surgery. I lateralize the handle of malleus. I do double breast technique. But of course, sometimes what happens, the situation is not very ideal. Sometimes there is a bit more use than the normal. So in such cases only, otherwise.
Go to microscope.
No, no, not. I have never converted so far. Once I started endoscopic, I never converted into microscopic, sir.
Yeah, good, good. So there's a question. Then when you will decide to convert to microscope, you need that this thing, but is there any indication when you have to convert?
No, see, there is no question of conversion. See, it is a beforehand surgery only. See, suppose if it is an extensive cholesteatoma, so as yeah, microscopic and combined, as Dr. Uday was telling, we can use both, but definitely microscopic. So we are going to do the that regular postal incision and all. So it's a beforehand decision only. And then see, you have to know what all and assess clinically, and then if possible radiologically. So then have a plan. Either it is a
All that planning, in case there is difficulty, you continue with endoscope, or we should be ready to convert to.
yes, yeah, of course. One should not be rigid. Yes, yes. So this is the corda tip. Yes, sir. So here I try to sir. Yes. No, sir. With naked eye. With naked eye. With naked eye. Endoscopically, ossiculoplasty is done, but sculpturing and then making a that hole into the that reshaped incus and all sickle knife. ಇದು ಕ್ಯೂರೇಟ್ ಮಾಡ್ಕೊಳ್ಳ ನಿಮ್ಗೇನು ತೊಂದರೆ ಆಗಲ್ವಾ ಇದು ಕ್ಯೂರೇಟ್ ಮಾಡ್ಕೊಳ್ಳ ಅವ್ರಿಗೆ ಸ್ವಲ್ಪ ಇದು ಇನ್ಕ್ಯೂರ್ ಸ್ಟೆಪ್ ಜಾಯಿಂಟ್ ತೋರಿಸ್ಬಿಡೋಣ put microphone. Proceed agano. Yeah. To curate. ಇದು ಅದೊಂದು ಒಂದು ಸ್ವಲ್ಪ ಅವ್ರಿಗೆ ಆಸಿಕ್ಯುಲರ್ ಇದು ತೋರಿಸೋಣ ಅಂತ ಅಷ್ಟೇ. ಇದು ಸಿಕಲ್ ನೈಫ್ ಅವ್ರಿಗೆ ಮಾತಾಡ್ಲಾ ಹೇಳಿ. ಇದು ಸಿಕಲ್ಸ್ ಎಲ್ಲ ತೋರಿಸಿ ಅದೇ. ಸೊ ಹಲೋ ಆಡಿಟೋರಿಯಂ.
Yeah, Shankar, there are a lot of questions here. One by one, we'll clear it. Now you tell me.
So this is the neck of the malleus, lateral process of the malleus. This is the umbo, that is handle of malleus, and then this is the long process of the incus, chorda tympani, incutostapedial joint. So you can see the lenticular process making a contact with the incutostapedial, this superstructure. Yes, sir. And this is glistening structure is stapedius tendon, chorda. Yes, sir. That is what. Probably because of the bone, it is fixed. Otherwise, the moving, sir. Can you see, sir?
Yeah, nicely moving.
Nicely moving. See, in fact, this is how in a normal person. In otosclerosis, yeah. So in otosclerosis, when we move malleus, the incus moves, but the stapes does not move. Again, when we do this, the incus moves, the stapes does not move. But here you can see the mobility of the stapes as well.
Restricted mobility is good for us. We can do something.
Yeah, yes, sir. So that is malleus, incus, and stapes, the stapedial tendon, the round window niche area. Okay, and now I'm.
And show the round window. Go closer. They want to see the round window. Round window reflex. It is too much to ask for, but again, you can just see.
I'll just see, sir. But yeah, maybe I have to clear a bit. Sir, you can see the movement.
Movement is there.
Yes, definitely there, sir. See,
Very good.
I'm going near.
And miliar pathways, airway pathways, and the miliar folds. There are, I think there is one fold still intact there.
So that I have to remove a bit of bone there. So this is the tensor, probably the tensor. No, sir.
It's anterior fold.
No, sir. The tensor fold. This is anterior malleolar ligament, sir. This is ligament. So attached from the this neck of the malleus to the anterior this annulus or to the anterior wall of the that tympanic cavity here. Yeah, but if you do not cut, better, sir, so that the stability of the malleus is maintained. Otherwise, also nothing will happen. Many of the
from north of Grommet, you are entering into middle ear. That time, that portion of anterior you are activating. You are actually removing the anterior malleus.
Yeah, correct, sir. But we can with endoscopes, I think we can spare it also. With endoscope, we can spare it. But as you rightly said, sir, many times it is cut. So this is anterior malleolar ligament, and then actually there is a posterior malleolar ligament also, which comes here. Many times that also we dissect it out when we are dissecting the north of prevenus here. Okay. So now that is thing, and now we'll go for. I'll remove this portion posterior superior canal wall overhang. Just like for stapes surgery. I'll try to do it. It is, yeah. It is fixed, sir. Drill like what?
If the Tympanoplasty patches, how to deal with it or during the
No, we can excise the tympanosklerotic patch.
There's one case I tried to do, but I lost most like.
Now, where was the tympanosclerosis? Innand ಬೇರೆ ಇದೆಯಾ curate? ಇನ್ನೊಂದು curate ಇದೆ?
So while freshening only, I tried to remove the patches, but some of the flap was lost. So thankfully the graft has taken up. But how to actually do it? Like it is expensive. Tympanosklerotic patch is very much expensive.
No, basically once you remove, it becomes a subtotal perforation or almost a total perforation. You have to graft. If it is extended,
Take off the tympanosklerotic patch.
Better. Otherwise, see, the hearing will be better if you remove the entire tympanosklerotic patch. Definitely.
Only time where the tympanosklerotic patch will be helpful is posterior superiorly, if it is there, you need not remove the patch. Because anyway you are going to remove the body overhang, that will actually promote any retraction. You are going to reconstruct stronger patch. That we can avoid if you keep the tympanosklerotic patch at that area. So it is easy to present.
See, I'm just removing this outer, this posterior superior overhang. This is the caudal ridge where it's a ridge of bone on the posterior wall of the middle ear and where the cauda tympani nerve exits. So invariably cauda comes in the way of during stapes surgery. We have to see ways and means to just preserve the cauda as much as possible. The moment you remove the bone over the caudal ridge, automatically it gets displaced.
An amount of body overhang removal also is less compared to microscopic.
Yes, sir, correct. Otherwise, it is impossible to see the stapedial tendon in microscope.
In microscope.
Yes. Without removing the this drill marble.
Yes, sir. It's ready, sir.
Can you use drills with the endoscope?
Yes, sir, we can do.
Like skater drill?
Yes, sir, we can.
Whatever the regular drill?
Regular drill also I have used, sir.
Okay.
Regular drill for I have used, sir.
Yes. Okay.
What about suctioning?
Yeah, suctioning, that's a challenge. What we do is I wet the bone, on ಸ್ವಲ್ಪ wet ಮಾಡ್ಕೊಡಿ. And then drill. Again, I wet the bone, suck, so like that. Correct. No, but assistant can keep sucking once it comes into the. See, this is how I work ಆಗ್ತಿಲ್ಲ ಇದು bone.
ಇದು ಆನ್ ಮಾಡಿ.
ಇರ್ಲಿ ಮಾಡಿ. This is what section ಮಾಡಿ.
Error from our side can actually destroy the whole. Very very flexible change. With endoscope,
ಬೇಡ ನೀರು ಹಾಕ್ಬಿಡಿ.
Need a lot of practice.
ಸ್ವಲ್ಪ ವೆಟ್
This
ಮಾಡಿ.
is what size per?
This is a 1.8 or 2 mm.
1 mm or
2 mm, sir.
2 mm.
And here we have to be careful not to damage the endoscope also. Section.
You can curate it.
Yeah, yes, sir. Now I think sufficient. This is a just mucosa.
Part is coming the way, in this case, you can't refract it.
I'll try to push it if possible. I'll just try to simulate as much as possible, like a live surgery. Otherwise, I'll cut it, sir.
Because now the time is
Okay, sir.
because the space also needs another, I think 1.5 to 2 hours.
Sir.
All the techniques.
Just this is, yeah. See, even in live surgery, if you push it, usually it gets stuck there. Flagna.
This temporal bone is quite favorable towards the surgeon.
Correct, sir.
Isn't it?
Yes, sir. True.
In fact, we have chosen the bone by taking a scan.
Oh,
Okay. We went to that.
okay. Anyway, it got cut.
What temporal bone we kept on the.
Perforator. Section.
So we have selected the bone because we wanted the maximum benefit for the delegates. The well aerated bone, the ASL.
So, sir, now I'm going to do this stapedotomy.
Yeah.
And after that, no, it, yeah. I'll just push it there so that, Shreyas will have a.
We can see the actually foot plates covered with some
Debris, sir.
Yeah.
Correct, sir. So if I clean, it will take time. So because as I'll just try to do it on top of it only.
Anyway, delegates are going to do this procedure at the microscope.
So this is the pyramid.
Yeah.
As you can see, stapedial tendon.
Yeah.
And then this is the posterior crura.
Yeah.
Straight.
Posterior crura.
That will be more clear under endoscopy.
Almost reverse Stapedotomy.
So this is, I'm going to do that fish technique, sir, where I make a fenestra. Yes, sir.
First you are going to do a fenestra.
Yes. And then see, this is the facial nerve.
You are using hand perforator.
Yes, sir. It's perfect, right? What is 0.6, sir?
Straight away is gone to 0.6.
Yeah, just for
That's what demonstration is doing, but in live we
0.3, 0.4, and then 0.6.
normally go for a smaller.
Yeah, first is 0.3,
Yeah.
then 0.4, then 0.6.
Because rate is fixed here. That's why it's not that much good for you.
Yes, sir.
You are doing the posterior half.
Yes, sir.
I think it is giving too much resistance. Little anteriorly you can go. Yeah. And as you see, Shankar, you using only the wrist of fingers movement. No need of drilling shoulder.
Huh?
Finger movement.
Ah.
Not even wrist.
Always in temporal bone dissection, it's better to do stapedectomy by reverse technique. That is, the first line the fenestra.
Sir,
Yeah, now yes.
the fenestra is done, sir.
That is a mistake.
Pistons,
Let's put the piston, remove the piston, put the piston like that, you can practice. Okay, but if you do the other way, that is the introduction joint.
Yeah. Correct.
The whole step is come on. And then, if you insert the Teflon piston, you will not get the feel of the piston. To get the proper feel of
So that is the fenestra, as you can see in the posterior half of the foot plate.
good. I think this person was something more what was
Maybe ಹೆಂಗೆ sir?
ನೀವು ಹೆಂಗೆ ಇಟ್ಕೊಳ್ತೀರಿ?
Same sir.
So I'm just inserting the.
all that measuring and all that we keep for theoretical discussion. You may enlarge it.
Yeah. Sir, actually the piston length is long.
Yeah.
So, but anyhow, see, it has gone into the lower end. And see, if the length is correct, it will just go and sit, sir. And I think, yeah. ಇದು ಓಪನ್ ಮಾಡಿ ಲೂಪ್ ಓಪನ್ ಮಾಡಿಲ್ಲ ಅಲ್ಲ ಮಾಡಿದಿರಲ್ಲ ಅದೇ ಓಕೆ ಬಟ್ ರೀಕಾಯಿಲ್ ಆಗಿದೆ ಅನ್ಸುತ್ತೆ ರೀಕಾಯಿಲ್ ಆಗಿದೆ ಸರ್ ಸೊ ಬಟ್ ಏನೇ shall I open and put it again?
You can also enlarge the size. You have time, no, but don't worry.
Sir, ನೋಡಿ sir, it correct here it has gone perfectly well.
Small fenestra stapedectomy.
Yes, it is a small fenestra stapedectomy.
So with the advantage of small patient can fly.
Sir, it has gone very well here.
We can fly.
ಹೋಗುತ್ತೆ ಅಂತೀರಾ ಇದು ತೆಗೆದುಬಿಡ್ತೀನಿ ಹೌದು so that piston has got recoiled. That is ಕೊಡಪ್ಪ forceps.
So any questions on dedicated till now?
Right.
Any questions? The whole live demonstration is being telecasted live. Okay, the web. Okay, we have sent the link in the group. If your friends are interested, they can open the link and they can receive them.
So I've just widened the loop. You saw, sir?
Center, you are doing microscopic and endoscopic stapedectomy. Which one you feel very comfortable at this stage of your life?
Sir, now ever since 2015, sir, I've not done microscopic stapedotomy at all, sir. So I've never had this one problem at all.
That is the reason.
Yes, sir.
And actually, you can, after this step is, keep the piston there only.
Yeah.
And after she finishes all the technique with her, and after I do labyrinthectomy, probably if it is long, then I can show the distal end of the piston.
Sir, it has got
Vestibular.
gone in, Allah?
Oh, gone in, sir.
Sir, it has gone in.
It has gone in. Enter you hold, keep the piston, since it is long now. I can show the distal end of the piston from the vestibular side.
Yeah, yes, sir.
The end of the.
Yeah, so the procedure is over.
Yeah.
Now,
Endoscope only?
yeah, endoscope only crimping also, sir.
Okay.
And then if it is not coming in the way, shall I dislocate the inclustostepital joint?
So we'll leave it like this.
Leave it. Okay. Yeah, Dr. Shreyas wants to leave it because he wants it.
Yeah.
So I am done, sir. My portion is over. Thank you so much for the opportunity.
In fact, an excellent demonstration.
Thank you, sir. Thank you.
The endoscopic, the temporal bone workshop, normally they skip all these things. But in this workshop, we took a lot of time because endoscopic pathology is emerging field now. And
Okay.
so in all our workshops, we want to introduce at least 2 hours of the degree of the procedure, which is more than okay, thank you very much, Ethan, for sharing your vast experience with us. Thank you so much, Mr. Seti. Thanks. Please join us. Yes, sir. I'm coming down. Yes. Now, Shreyas, we are with you. You can just tell us before going, what is the sequence of procedures you are going to show? Yes. Yeah. Dr. Shankar, you are there with us? I'm coming down. There's a question here. Tell me.
Hello, sir.
Hello.
Light.
Hello, can you hear me? Yeah.
Actually, where I like trying to bring towards the lenticular bundle or towards the body of the
No, see. No. It is always on. See, we have to crimp it on the piston rests on the long process of the incus only, no? So we have to crimp it there only.
That 2 articles of publication does liquidity of taking and not and thing is that it should never be too low because it not be stable. The rating of the incus changes. If it is too high, it can come in contact with the patient. This to think we should take. But it should be a tight clamping and where it would be exactly here. So the gravity is that it should not be too high when it comes in contact. Just too low, it is get tight. After crimping, what I can do, what we can do later. What I can do then, just let the contact. Sometimes you can take count. It not depending on arrangement, they're actually doing the procedure, whatever is possible.
Hello.
Yeah, if you need a lot of conversation, nothing wrong. We can put on the phone. If too much time has been taken, a lot of other
So, hello.
Yes.
Yes, good morning, everyone. So I'm Dr. Shreyas. I'm working as an ENT surgeon at Meenakshi ENT Hospital. I welcome you all for this program, to all the delegates and the faculty members who have been a constant support to us. I welcome you all, sir. So firstly, I would like to thank Pradeep sir for giving me this opportunity and letting me dissect in the first half of the program today. So before we actually start off the dissection, I would just like to introduce the bone. So let us just orient ourselves. I'm in the lowest magnification possible. Pick please. So this is the external aortic canal. What we have here is a right temporal bone. I hope I'm clear there. I'm on the lowest magnification right now. So this is the right temporal bone. Like you all know, just a minute.
Yeah, better. You are doing fine focusing. Fine focusing is discipline.
Okay. Is it okay now?
Yeah.
Probably there is a lot of soft tissue in this area. Once I use a drill and remove some of this, it may become clearer. So we have the right bone. As you all know, temporal bone is predominantly formed by 4 different parts. The major lateral portion is this portion, is the squamous portion of the temporal bone. So this actually attaches to the parietal bone, it attaches to the occipital bone. So this forms the outer and the superior portion. Then this prominent portion, what we see here, okay, is the mastoid portion. Here is where the sternomastoid muscle is attached. They say the pull of the sternomastoid and the digastric is actually what causes this prominence in the first place. The smaller but the more important part is actually the tympanic portion. Right now we have a lot of soft tissue and skin, but we will slowly remove this. In fact, it was more clearly visible and appreciated in the dry temporal bone which we saw earlier. So the tympanic portion is this almost, I would say, starting from here, it goes up till here. So anteriorly, the tympanic portion attaches with the squamous portion, forming the tympano-squamous suture line somewhere over here. Once we remove the soft tissue, it may become even more clearer. And the tympanic portion will again attach to the mastoid portion that is here, and it forms the tympano-squamous suture lines. So the more prominent these suture lines become, the external aortic canal becomes more narrower. So in the process, we may have to do some sort of a procedure, a canalplasty perhaps, to actually increase the width of the canal. Okay, we can discuss that later as we go. And the more important part, the harder portion, is actually the petrous portion of the tympanic bone. And let me just rotate the bone and show you. This is the more harder portion, and it attaches with the mastoid, the squamous portion, it lodges some of the more important structures in the temporal bone. Okay, are we clear till now? So in the squamous portion of the temporal bone, there is an extension anteriorly. So this is the zygomatic process. So it is cut here, but the zygomatic process attaches to the zygomatic bone anteriorly. And if you see this groove here, okay, so the zygomatic portion extends more posteriorly. You can see this distinct groove here. There is one a line which I can see as we go here. So this is the inferior temporal line, or the inferior attachment of the temporalis muscle. So that is one point, and also an extension of the zygomatic process posteriorly. So this forms the superior limit actually for our dissection, and approximately it tells us where the tegmen or the dura of the middle cranial fossa is going to lie. So this demarcation, they still say about 5 centimeter, 0.5 centimeter above is where the dura will be. So we are safe to actually extend 5 millimeters, 0.5 centimeters. So from here is where the dura is expected. So you can still safely go up till here, but we can start and we can trace the tegmen as we go. So this is going to be one of our superior limits for our dissection to begin with. Okay, so where do we start our dissection? See, we normally go from one known landmark to another. So one of the most constant air cells in the mastoid system is the mastoid antrum. Yes, sir.
Neural line, is it straight or is it as a curvature?
So in the the first part, it is actually quite straight. Later on there is a mild curvature more in the cephalic area to the cephalic side. So that is because of the curvature of the middle cranial fossa. Okay, and if this is the external canal, if we draw a tangent to the posterior wall of the external canal like this, then it forms a triangle. So superiorly we have the linea temporalis, we have the external canal, the posterior wall of the external canal anteriorly, and a tangent drawn to the posterior wall of the external canal like this. There is a triangle formed. This triangle is called the McEwen's triangle. So McEwen's triangle leads us to one of the most constant landmarks, which is the mastoid antrum. So it is said that about 0.1 to 1.25 centimeters from the McEwen's triangle, we will be able to find the mastoid antrum.
Yeah.
Okay, are we clear? So my superior limit for today's dissection is actually going to be the tegmen antri and then the tegmen tympani. Okay, my anterior limit is going to be the posterior wall of the external canal, and posteriorly we have the sigmoid sinus. So the sigmoid sinus situation may be slightly variable, and that is going to be the posterior limit. We are going to go inferiorly till the tip of the mastoid. So this is the boundary or the limit of a cortical mastoidectomy. So this is one of the most commonly performed exercise in everybody's practice. So what we will do is maybe remove the soft tissue which is covering the uh, area of interest now. Okay, so as we go, we'll discuss about different types of burrs we are using. Right now what I'm using is a conical burr, conical cutting burr. So we'll use a large size suction. Constantly irrigation will be happening, and larger suction, and we'll use a conical burr because see, the whole idea of a cortical mastoidectomy is we first actually remove the cortical bone. Okay, then once we remove the hard cortical bone, we actually experience a softer diploic bone or a cancellous bone, and again when you will reach the tegmen, again you will see hard cortical bone. So the moment you step from the soft bone, again you're looking at a hard bone. That means there is some important structure. Okay, so we will start our dissection in the McEwen's triangle. There's a lot of soft tissue here. I'll just try to clear it off with the drill itself. Let's see if it works. So my first exercise, let me just uncover. I actually want to start off with creating a trough for varia procedure.
Can you tell the sequence of procedures we are going to do? Like first you said you are going to do a bariatric.
Yes, firstly we are going to do varia technique,
Followed by mastoidectomy.
Sorry?
Cortical mastoidectomy.
Yeah, so, cortical mastoidectomy, and we will be doing the post-tympanotomy, facial nerve decompression.
Yeah. Okay.
Yeah, I think that's about it. And later on, Pradeep sir will continue. The soft tissue I'm not able to drill out. We'll use a blade to maybe take it off.
Yeah.
It got it. Forceps.
Coming to the types of the burrs, what Dr. Shev was telling. So there are
Forceps.
diamond burr and coarse cutting burr and polishing burrs. There are 4 types of burrs. And coming to the shape of the burrs, there are conical burrs, round burrs, and
Forceps. I'm trying to remove the soft tissue. I thought I could take it off, but there's a lot of tissue here. It may not come off just with the drill.
Yes, Uday here.
Yes, sir.
Just wanted to know which is your
This is
preference when you start doing the standard
fine,
labyrinthectomy?
final.
The burst size, preference of the burst size.
I would start off with a large burr, sir, preferentially.
What is your
Maybe a 6 millimeter burr. Many a times I actually use the conical burr to start off with, and later the moment I remove the cortical bone, I switch over to a round burr.
oh, because I just wanted them for this on the candidates here, just to share our experience. Sometimes with the conical burr itself, you can do
Most of the
all
procedure.
the
Yes.
once you get used to that conical burr, I think the other ones become very difficult. You feel like the feel and the type of that is different.
I totally agree, sir. A large part of the cortical mastoidectomy is many times over, especially if it is a well nematized mastoid. A conical burr will make things very fast.
and also the conical burrs are
Fine tip ಕೊಡಬಾರ್ದು.
shorter, better
Fine tip
maneuverable,
ಕೊಡಬಾರ್ದು.
whereas the round burrs are little long and with the straight axis it becomes difficult to maneuver. And the other types of materials is stainless steel burrs and the tungsten carbide burrs. Most of the stainless steel burrs last only 2 or 3 cases, whereas the tungsten carbide burrs last a long time. And coming to the cutting burrs are shaped in such a way that they have got flutes. They say flutes. What you see, each blade is a flute, and in between two flutes, it is scientifically designed so that the bone dust doesn't stick to it. It is designed like that. In the flute shape. In the flute shape, the debris collection is less compared to on any burr. Cutting burr is flute shape. And each blade is a flute. Between two flutes, see the burr, if you turn the burr and see, the flute runs like a spinal. So it's not like circular. It runs like a snake. So if burrs are shaped like that, then the debris collection is like a flute. And second thing is the cutting burrs, they cut the tissue faster. And coming to the size of the burr, the larger the burr, it is less dangerous. It cuts more, but it doesn't penetrate. Whereas the smaller the burr, the pressure is more, it penetrates but cuts. So smaller burrs are dangerous. So in any given anatomical situation, the largest burr possible should be used. And cutting burrs produce less heat compared to the diamond burr. So diamond burrs, they cut less, but they produce more heat. And so a lot of irrigation is necessary by using diamond burr, especially near structures like patient. So these are some important things we should know about. And
Yeah.
diamond burr, as one of the delegates is saying here, diamond when there is a bony leader, the diamonds are best. Without irrigation, if we run on the leader, the nutrient presence will get blocked. You must listen better with diamond. The sizes actually start from 8 mm onward. 8 mm onward, the burr starts up until 0.5 and even lesser than that. Very small burrs are also available, especially when we want to use for ossicular plastic, culturing the ossicles. We use very small diamond burrs, cutting burrs. So all the sizes of the burrs should be available just during the burring. And also the burr run in 2 dimensions. Okay, in forward mode and the reverse mode. Majority of the dissection is done with the forward mode. But then why there is backward mode? Very rarely we use backward mode. But we use backward mode when again you are using near structures like facial nerve or tegment and all. But here, instead of using cutting burr, we are actually touch diamond burr. But in case you want to use the cutting burr in this case, then you can use it. So there is nothing like oscillating mode in the autology burr. That is available only in the endoscopic sense.
Sir, I've actually cleared the the external canal skin here, as we spoke. This is just to hasten the process because the first exercise is actually going to be the Varia technique. So for Varia technique, we actually lodge we create a small trough. We start off just like a cortical mastoidectomy, just that we create a small trough here to lodge the excess of the coil of the electrode here. So we want to expose the external auditory canal also. And since this is a cadaver bone, we will not be able to elevate. We have not used any retractors to keep the flaps anteriorly. That's the reason I've excised this bone and had this entire posterior canal wall in view now. Is it appreciable? Okay, so this is the posterior wall of the external auditory canal. We can appreciate the small projection here. This is the spine of Henle. It is present in the posterior superior portion. If you see, there are small pit-like, depressions here. This is actually the cribriform area. This is where there's a lot of communication happening between the mastoid air cell system and the outside skin. And there are a lot of emissary vessels and veins. The actual big emissary veins is located somewhere posteriorly, that which communicates with the sinus tympani many times and cause bleed, can give rise to some amount of difficulty at that time, especially if we are working more posteriorly. But for a regular dissection, yeah, I think that will not trouble us much. So with this in view, let us start the dissection. So I'm using a conical burr. Please. So I'm marking my superior limit actually, because there is soft tissue here, it is slipping. So I'm using it in the forward mode, yes. So this is the first line of the thing, first mark I would say. The next mark would be along the posterior wall of the external auditory canal. So this is the spine of Henle, and slightly posterior to that, we will go all the way. You can go till the mastoid tip. I think I should elevate a little more skin there. Okay. Now that is going to be my anterior limit, and we can remove all the cortical bone between these areas. So I'm trying to remove the soft tissue first.
Area technique is done for proper implant. So if you do this kind of technique available today for the complex implant, what is area technique? Other important is for so first we are going to start with the area technique. And we see the first consideration we have this and then we have to go to the next action. And when we know what is actually doing that, like very and many people nowadays are doing very attacking lead dependent method of doing a complex implantation. Lot of controversies are there, lot of limitations. That is not
Start for it, yeah. Start बरಬೇಕು ನನಗೆ yeah. What I'm
one of the most experienced area surgeons, he especially they are like a very narrow exploration canal, denoting exploration canal and all that. Yeah. See, but surgeons should learn all the things. And we should be free to decide and what to do. If I don't better with all the techniques, I know what to do. This is the area of culture, so this is my personal choice is variation. Because variation is very simple to do and you can do faster, then you is showing now, you just make a drop and then you make a tunnel and you will insert the so there is no complete mastoidectomy, there is no Epitympanum and then do Cochlear. The only thing is in variation you have to lift the implant. Whereas in Epitympanum technique you need not lift the implant.
Yeah,
And every day will be
sharper.
for other purposes. Why not for variation? Learning curve also is less in the variation compared to both.
I'm sort of opening the mastoid here slightly. So in the process of creating a trough, actually we are starting our dissection. Unlike the classical varia technique, where a trough would have started all across here, this is a slight modification, I would say. So we are creating a trough, and through this trough, we are thinning the posterior canal wall such that we are able to insert the varia probe or the introducer, and that way we can secure our introducer basically. If somebody has seen the varia technique, they will understand. If not, I'll be showing it now.
You have to definitely do the first. The state electrode implants, which are cheaper than the electrode implant. The radio technique may damage the patient mind. It is done blindly. But here, Dr. Shaykh is going to show the proper perforator, Hans perforator, if you use properly, then we can safely do a tunnel. And this tunnel he will be tracing until the end. He will be showing the track of the tunnel he has made, and at the end he will show how far it is from the patient.
So
then you get convinced that
small.
also
18
right, but it is guided. If you use guided, if you proper
ಎಲ್ಲಾನು ಶಾರ್ಪ್ ಬೇಕು
posterior.
ಇವಾಗ ಆಯ್ತು ಎಲ್ಲಾನು ಶಾರ್ಪ್ ಬೇಕು ಇದೆಲ್ಲ ತೆಗೆದ್ಬಿಡಿ
What is the incidence of patient of carotid failure becoming potent? I think both will be equal. The surgeon who can damage the variation will also damage the posterior. Or the patient of force, if it is such a way that it is damaged in variation, also gets damaged. But according to me, if the patient's nerve is anomalous, it is all the more indication for variant, not for the posterior. Because the variant technique you see now, the tunnel is made within the thickness of the posterior canal wall. It is not outside the canal wall, it is within the thickness of the posterior canal wall. And you will agree with me, the patient nerve will not enter into the thickness of the.
So the idea of the varia technique is basically to introduce the electrode into the cochlea without having to do a complete mastoidectomy. So that is probably the idea, or to simplify the posterior tympanotomy was why the varia technique was introduced. Because sometimes, or in majority of the times, most of these children don't have a mastoid disease. So the idea is just to introduce the electrode. So if we could do it in a simpler way, why go through the hassle of doing a posterior tympanotomy was the idea.
Yeah.
So for this, what was identified, what was the philosophy of this is that facial nerve never enters the external auditory canal.
Right.
The facial canal and the external auditory canal, maybe there's a small distance, sometimes there's more distance, but never will the facial nerve actually enter into the external auditory canal. It is never that we are elevating the tympanic membrane, we are trying to elevate the annulus and facial nerve gets damaged.
Yeah.
So when it is like that, then if we create a small tunnel through the thickness of the external canal, not into the mastoid actually, but through the thickness of the external canal, then which will lead us to the mid layer and the cochlea, then why do the entire posterior tympanotomy was the philosophy.
Yes.
So to do this, we'll be showing both techniques today. And personally, I don't have any, take about both this thing. Pradeep sir likes Varia technique. I actually like the posterior tympanotomy technique, but I will be demonstrating both the techniques today. Okay. The only reason why I say I like the posterior tympanotomy technique more is because it is more versatile and gives me the option of introducing different types of electrodes inside.
Yeah.
So to have that, to create a tunnel through the external auditory canal, we have to have a straight canal. That is the prerequisite. If you see, the canal is smooth here, but as we come here, it is actually tilting.
Yeah, curving. Yeah.
Curving up. Okay. So if I have my introducer is a straight one like this. So I have to be introducing in somewhat in line with this canal here. So I need to have this part drilled out such a way that I'm straightening this canal wall. Okay. So that is what I will be doing now. I'm straightening my canal wall now. I'm also removing the soft tissue in the process. And ಸ್ವಲ್ಪ ದೊಡ್ಡ section ಕೊಡಿ.
In the discussion now, there is one more technique called hybrid technique. In hybrid technique, it is satisfied both the various it's all Poca techniques. And here, what you do is, but not going for it. Opening the antrum and then doing better. So that is the accuracy that we can have here. I think great you can do the Poca technique also.
Yes, yes. I'm almost doing it like Bhopal technique only today. Trying to get rid of the soft tissue. Blade good.
There is a question here.
Yes, sir.
Endolymphatic you are doing
Yes.
using cutting bar. Is cutting bar advisable by doing endolymphatic?
In fact, the idea of the canaloplasty, one of the concept is that yes, you're widening the canal, but you're also opening up the Haversian canals when we do it. If you use a diamond burr, you're closing off most of the Haversian canals. This is so that the vascularity of the flap is actually, the corner's flap is actually dependent on, including the tympanomeatal flap. It derives its vascularity from the bone. If you close off all the vascularity, we are actually dividing it of the vascular supply. Yes, it's a free graft. So we need to have it, and we preferably want to do it with a cutting burr. So what I'm trying to do now, I've probably taken off a little bit of spine of Henle. I'm straightening the canal here, and I'm thinning it also. It is still not straight. It's not in straight line. So I'm straightening a little more.
I think there is something you have to tighten little deeper.
Yes, sir.
You do it very attentively with the right side, from the right temporal bone. You have to use the left hand. And using the hand perforator with the left hand and making the tunnel. It's slightly
Clear cell the clusters.
the complex implantation is done the bilateral depth child. You prefer to go on the right side. Right temporal.
Right side first, yeah.
On the right side, the child can use the outer or the visible accumulate comfortably in the right hand rather than the left hand. So if you unilateral complex implantation, the bilaterally performing the child, it's better to check what you find.
18 number section.
That is leading action. But in temporal detection, practice sometimes.
Sir, actually the Teflon piston is in close contact with the scutum actually here. So if at all I try to enter, I may actually dislodge the piston. Is it okay if I remove the piston?
In fact, you have
My-
to remove
Yes.
in case of complex implantation, the piston is there, you have to.
Okay. Right angle pick,
But it is not a
microforceps.
because many patients if hearing aid then they decide to go for the cochlear implant, then you have to.
It is not.
It's a possibility, rare possibility.
I would say the canal is not fully straight here. I would still want to straighten maybe the outer aspect here still. I know it is very thin.
How you deepening the inside portion? The body overhang, it is the body overhang which is giving the curvature like that.
Correct.
You are there because you will smaller burr and tighten the area. Yeah. But you can use the diameter also.
Yes.
Just little bit will be become okay.
I think it's almost okay. Yeah. ನಂಗೆ ವೇರಿಯಾ perforator. So we have a special instrument which has actually been devised by Dr. Hans. It's called a perforator for the varia technique. Just like our normal handpiece, this is our normal handpiece. We are able to attach a burr to it. In the varia perforator, the handpiece has been slightly modified. There are two things. One is a guide. What we see on the left is the guide. Let me just yeah. What we see on the left is the guide. What we see on the right is the burr. The burr is also slightly different. If you notice, I'm keeping a normal burr on the side. This is a diamond burr. If you see the thickness of the shaft is much thinner in here. It is the regular burr up till the point it enters the handpiece. But from here onwards, it is actually a much thinner shaft. It tapers, yes.
Distally it tapers furthermore.
Furthermore, correct. And we use, this is a 0.8 mm cutting burr.
Yeah.
Okay, this creates a tunnel of about 1.2 millimeters. Okay, so this is a right temporal bone, and we have specifically chosen the right bone because many a times, if at all we are doing an implant unilaterally, then we start off doing it on the right side. This is because majority of the children are right-handed children, and it is easier for them to handle their implant. Okay.
And this area of what you said, the operator.
Yeah.
Area perforator. Can you attach to any other handpiece?
Yes, it goes to every handpiece. It's just an attachment. So you remove, we've just connected it to the same handpiece. This is a marathon handpiece I'm using today. So everybody can use it. Okay. So there is a guide which is going to be placed in the external canal. It is going to be guiding me along and telling me where the actual cutting of the burr is happening. And I will be starting, pick please, from about 10 or 11 o'clock position here and going all the way. That is going to be my line of dissection. And the hope is that I would not come out through the external canal, but even if that happens, it is not a problem.
Yeah.
It is not that I should not enter, but it should not hit the facial nerve. That's the whole idea.
Yeah.
Okay, and I'm supposed to be coming out somewhere at about 9 o'clock position, somewhere here, so that it is closer to the round window which is there. Okay, so 11 to 9 o'clock position. And to do this, I'm actually using my left hand.
Yeah.
So I have to do telescopic movements up and down like this.
Yeah.
And come out till this area when I'm continuously running the burr. This is the only challenge initially.
Yeah.
If not, it is a relatively simple technique.
Yeah.
Okay. A lot of irrigation should happen. So the assistant is supposed to be irrigating as we do, suction to one hand.
Was made so that this will engage the burr and the guide will engage.
Dappa dakodi.
And
Salpa.
now you understand why striking was made.
Salpa
So
dappa.
that goes into a direct path. And it should be just below the bone. Even if you enter the bone, doesn't matter. You can always use the bone just and you can do.
Okay, so I'm starting.
Yeah. The direction of your participation is almost pointing towards the east of the line, no?
Yes, sir.
So that is approximate way.
So I'm making telescopic movements.
Movement. And you see the guide is always touching the bone. See that? The guide.
I'm through. I'm through. Here we actually, still perforated the canal. This is because we had a curve in the canal.
Yeah.
So it is still okay. We can cover it with bone dust at the end of the procedure.
Also, you are going to use the temporal fascia.
Correct. We are also going to use the temporalis fascia and the bone dust. It is still okay. So if at all this happens also, this is not a problem. It's more important that we are able to secure the electrode inside and not hit the incudostapedial joint in the process. Okay?
And also, even though it was blind, it is within the thickness of the canal wall.
Yes, within the thickness. I've actually directed it. So we are actually able to see I'm not sure if it's clear there. Yeah, the tunnel is, I'm focused it in line with the tunnel. So because there was a small angulation to the external aortic canal, and if I had thinned it out even more, we would have compromised the safety of this area.
Yeah.
That's the reason I didn't decide to thin it. It's still okay to have a small buttonhole into the external aortic canal. So we will leave this canal, we'll trace this up till the end of the procedure just to see how far this tunnel is from the facial nerve. So we all get confidence that we see ourselves whether this is very close to the facial nerve or is there good amount of distance.
Yeah.
So actually let me use a 20 size or 21 size suction tube just to show you that this is something which has actually can enter into the middle ear. Okay, can you see that near the round window?
Just move the suction tip.
Yes.
Out of the center. Move the suction tip. Yeah, can you see that suction tip there? So Cochlear
Suction, please.
there on the promontory.
18 number suction.
Enter to the round window. So if the Cochlear is made there, directly the electrode.
This is our round window here.
I think you have to do the cochleostomy also.
Okay, we'll do the cochleostomy, but we'll not be introducing the electrode today in this step. That's because inget kobeko.
That's because
Inget kobeko.
contour electrode.
because we have a contour electrode, and that's the limitation of the Varia technique. So we are not able to introduce any contour electrodes through this.
Okay.
ಒಳಗೊಂದು ಬಟ್ಟೆ ಇಟ್ಕೋಬೇಕು and you have to lift it ಕೆಳಗೆ. Suction please, and saline wash ಕೊಡಿ sister. Maybe bigger size suction. Off. So can everybody appreciate the round window?
Yeah.
Okay, now give me a pic please.
Yeah.
18 number suction.
Both back. After that tunnel, there is the exposure of tunnel like this.
Huh.
Both back and then the temporary fascia, both back.
So I think it could be used, but I would prefer maybe not to use bone wax. I've not tried it. The only this thing is, suppose we have to revise, I don't know how bone wax will integrate with. Bone dust is better because I don't know what is the integration of the bone wax with electrode. So majority of the places everybody uses bone dust to cover, and a lot of bone dust is generally generated also, so it should not fall in short.
Isn't it? When there is a lot of bleeding from the bone, you can't stop bleeding in another way. You will lose the bone back. But here there won't be any bleeding.
I'll slightly maybe excise this portion of the pars tensa for better visibility.
Use the crocodile forceps.
Yes, forceps. So I know Shankar sir has taken a lot of effort to preserve. Okay.
Yeah.
Brother, don't shake, please. Okay. Now pick, please. This is
insertion. One is through the round window or making a
yes. I was about to say the same thing. This is the anterior lip of the round window. This is the posterior lip. Of course, the visibility is not as great as the endoscope. I am sure all of us will agree. So this is called the round window niche. The round window is actually not a membrane which can be directly visualized many a times. That's because this bony overhang which covers the round window. This bony overhang is actually called the operculum. Okay, so what we'll do now is slightly drill out the operculum. I'll be using a small diamond burr to do this.
That is called ossiculectomy. Do you do this ossiculectomy in all the cases?
So for a round window insertion, sir.
Round window.
Yes. Yeah. So I'm using a 0.8 mm diamond burr now. Yes, thank you. So please let me know if I'm not in field.
Yeah, you are in the center of the field.
ತುಂಬಾ ಮೂವ್ಮೆಂಟ್ ಆಗ್ತಾ ಇದೆ. ಸಿ ಏನ್ ಪ್ರಾಬ್ಲಮ್ ಅಂದ್ರೆ ಎಲ್ಲೋ ಇಟ್ಟಿದ್ದೀರಾ ಇರಿ. ಜಸ್ಟ್ ಗಿವ್ ಮಿ ಒನ್ ಮೂಮೆಂಟ್, ದೇರ್ ಇಸ್ ಸಮ್ ಇಶ್ಯೂ ಹಿಯರ್. ಇನ್ನ ಕೊಡಿ ಬಟ್ಟೆ ಇಡಿ.
When you going to introduce the injection because you are turning the canal wall and you are lifting up the normal tympanic membrane. So the chances of a infection the post surgical time. No, you are going to the saline. You are already saline in the surface area.
Okay, la? Stable la?
So that was one of the that was the concern. But it was theoretical concern. For any surgery for that matter, you can introduce infection even through prostate intervention. Why not? And there were some people asking that you are lifting the tympanic membrane and so you are doing so. That's the infection. And you are doing that for medication. Yes. For definitely you are lifting the
ಕಮ್ಮಿ ಆಗ್ಬೇಕು, ತುಂಬಾ ಕಮ್ಮಿ ಆಗ್ಬೇಕು.
they are all theoretical considered, and now the experience shows that like thousands of
So what we are
area patients are there now, they be comfortable. And that is just a testimony.
So what I'm doing is only drilling the lip.
Yeah.
Okay. This is called the round window lip also. Come here.
What is the size of the bird?
0.8 mm.
Diamond.
Diamond bird. Hackberry. So can you see the round window is coming into view slowly? I still have to remove a small portion of the operculum.
It is obliquely situated.
Yes.
Horizontal.
Better, better.
Can you see that? Yeah.
I won't remove more superiorly. Yes, that's the round window. Can you all appreciate?
Yeah. You can now press the step superstructure.
You can little more focus and press the
Step superstructure.
we only visualize the round window reflex.
Yeah.
Okay, it's high magnification, but let me try. Yes.
Yes.
Yeah.
Yeah.
With low magnification you show.
Okay.
Lower. Now you show.
Let me move the malleus. It's quite fixed actually.
Don't know, it is auto screw.
Already you have penetrated. You have done the penetration already.
Yeah. Yes, sir. That is also probably one of the reasons. Okay. So for a round window approach, we normally remove, this is the round window membrane here. There's still a piece of bone, this one. We can actually remove the membrane here and
Use the needle for that.
yes, go ahead. Or as an extended round window approach, we can remove the inferior, the anterior lip of the round window. In the inferior portion, this portion actually forms the crista. So crista of the round window is actually one thing which it's a small ledge of bone which actually maybe doesn't give us a direct path into the scala vestibuli.
Like a step.
Scala tympani, sorry. It's like a step. So during this, if we remove this crista, then we are able to get a more direct access. This is called the extended round window approach. Okay. Alternately, we can also create a small, opening, a cochleostomy in the antero-inferior aspect, somewhere here, over the promontory, and take one more direct access. This is called a cochleostomy.
Yeah.
Okay, so there are three different approaches. One is through the round window membrane, which is here, which is not the most direct access because of the presence of crista. You shake marta idira. Because of the presence of the crista, it can also, we can go through the extended round window approach or through a cochleostomy here. Now, what I'll do is I will extend the opening a little more inferiorly here. Okay, in our very system. You are
You're using the straight axis or angled axis?
I'm using a straight axis.
The whole idea is your electrode should be the scala implant.
This will give us a more straighter axis for insertion.
And your electrode should not be in the Epitympannic.
Yes, sir. So yes.
So that's the reason it will be very careful to put in the right way.
You can already see
You can see the round window more clearly now.
More clearly.
And open up the round window, I think you can see the Krishna. You can easily open
A round window is open.
it. Fully, completely you can see.
Yeah. Align for you.
Yeah, it's an extended approach. It's doing extended approach.
This is an extended round window approach.
When the Krishna is forming, when Krishna is
And there's a
forming,
prominence of the
you cannot
crista.
insert the electrode. Yeah, or on the table, you feel the Krishna is. But as I said, it should be inserted on the table.
But majority of the insertions today.
You have decided to do round insertion, and round insertion is difficult because of prominent Krishna. Then it will be ready to extend. Or alternative, go for the Cochlear.
Sister.
Now studies are again first actually you see the history of Cochlear implantation. They started with
change ಮಾಡ್ಬೇಡಿ.
Okay, when I went for the Cochlear implant training, everybody was talking about. Then the study came that it should be Cochlear is better because sometimes is difficult. Now again the people are going back to round window insertion because of electrode dynamics are improving. Insertions are improving. And
So if you can.
This is less damaging, less hearing result compared to Cochlear. You are making a new opening, new damage, new opposing damage.
Ready.
That increases your damage more. The residual hair cells are getting damaged. So they are
Sharp.
back to the round window.
Super sharp.
Residual hearing preservation is the key point.
So now, if you can see with the extended round window approach, the moment we remove the crista, we have got a wider opening now. Okay, we will be easily able to insert our electrode and be able to introduce any type of electrode. So even the more thicker electrodes from the middle will be able to easily go through this. Okay, so we'll be using a contour electrode. So let's do a post-tympanotomy and then insert through the same opening. Using the contour electrode. Okay.
Yeah.
Yes.
Another reason the incidence of Epitympanc insertion has reduced after round window. During Cochleostomy, they used to do Cochleostomy in the wrong place, and they used to put the electrode, and it used to be
blade.
But with round window insertion, definitely you know that it is going to not do that. That is another.
Brother, ತೆಗಿಬಹುದು.
So that finishes the bariatric.
That finishes, yes sir.
So implant electrode insertion was not shown because we are going to use the dummy electrode. What we have got is the contour.
One day.
The dummy electrode is costing 50,000. And that's the contour electrode. So contour electrode we cannot insert with the bariatric. That's why it's going to show
A knife.
Through the body. You see the funnel bariatric, the electrode goes directly to round window, extended. You can imagine. After stage, you can put a small suction tube through the bariatric. Imagine that it is an electrode and push it inside the extended.
Yeah. I think I showed the suction tube.
But now we show it to the round window.
Okay, small suction tube, please. 20 or 22. So luckily, I think I have the straight axis, and I can see it reach up till here, but I don't have it because it's not a malleable thing. Yeah, I don't think I'll be able to. Yes.
The blind procedure, but he will be showing now as he starts dissecting the bone.
you will see the track, how the track, the end he will show the facial nerve, how far is it from the brain. Then you will all get convinced that variant tunnel also is
Sharp.
So now you are going to do the cortical.
Yes, sir. So I had my initial lines of dissection. So, sorry.
Yeah, you can lower the magnification.
I think I'm on the lowest magnification. Oh, no. 1 second. Yes, this is.
Yeah, same. Yeah, this is
Dappat section. Sharpers ಕೊಟ್ಟಾಯಿಲ್ಲ ನನಗೆ.
There's a question.
Yes, sir.
At this stage, can you tell if there's an anteriorly
ಹಳೆದದು.
sinus?
Maybe difficult to say, sir. If at this stage anterior placed sinus, there's no evidence so far. Maybe if I open a little more, then I will be able to say.
It's a very aerated mastoid.
Yes, it's an aerated mastoid, so we are hoping, but the aeration doesn't mean that we are not going to face an anteriorly placed sinus.
All the air cells are formed.
Yeah.
So, relate to that video question. And I just think kind of breathing.
Yeah. Sharpers ಕೊಟ್ಟಾಯಿಲ್ಲ. Actually, the burr happens to be a little blunt today, so I'm having to put some force here. Yes, sir. I did try, but I felt that was also very blunt. The bone is quite hard actually today. So what I'm doing is decortication. I'm removing the hard bone which is covering the outer lateral aspect. So once we do this, the decortication actually is a time-consuming process. We'll remove and expose all our limits. We'll go as posteriorly as possible. Sorry? Yeah. I think I'm putting a lot of force and trying to remove. That's the reason. Just a minute. Just bear with me for the next 5 minutes. I'll just decorticate this bone, expose the mastoid hair cells till the tip.
Now you have to actually you have to select your anatomy of the mastoid muscle system. So when you look at what are the verticals, main of the verticals, everything is so the mental vertical system is to welcome and it is the surface area of the mucosal cavity. So here each air cell has a mucosa and it has got a venous system. And when the air enters into these air cells, there is actual ventilation system. So your nitrogen is filtering into the air from the plate. You see the air is the air cell, and when the air cell is into the environment. Structure. But there are times when the usage to the object flow, specific Second, we can enter labor system and the system. So, labor system is better. And also the way of delivery. And you can see, you can name the air. So the anterior is the zygomatic air. Which is the air. Sinus, airfield, sinus, airfield. And then the airfield is the airfield. Six airfield. Very labyrinthine airfield. So all these airfields have your extended label. The mind you go to tell you that you are extending the label. It is like endoscopic kind of thing. When you are entering the prostate point, your mind is telling prostate point. And then the blood, again will be clearly in the mind what airfield you are doing. So that it will not damage the system.
It's very hard bone that we are facing.
Yeah.
A little bit sharper burr system.
And the most constant air cell is the mastoid.
Small.
That's why we speak the mastoid in the beginning. And then there we know there is atom is center the canal, and that will give us
And also said, could you please?
like that we give from one landmark to another landmark. So if you depend on some other air flow, so when you will encounter fever of bacteria, the fever of body of infection or serious in the body, but on after there will be not or partially covered. The partially covered bacteria system is called the equivalent system. So for that reason, you will encounter air cells, different types of air cells. And today, before doing the mastoidectomy, it's always better to have a scan. Now, a scan is mandatory to do, like scan is mandatory to do endoscopic sinus surgery. Scan is mandatory even for to do the Tympanoplasty and all that. You will know the air cells, and then we can open up. Any doubt?
Bone appears to be a little. Blunt ಇದೆ sir. Get me the next. Get me sharp burrs.
Otherwise, based on the trigonometry and also the microscopic findings, you can do the fluid can be done. Because in fluid, you are not opening the mastoid. You are just opening into the midway. But nothing wrong if you are actually doing some other purpose, like for diagnosing adenoid in this case, or suspecting anything else. Can do nothing wrong. If you do, you can still see the glue in the mastoid. Yes, you do the scan. You can see glue even in the mastoid. Yes, there's a still there, and it's completely heavy. But there's no destruction. But it is not mandatory. To diagnose fluid, the treatment can be done.
So I've got a sharper burr now. So I'm proceeding. I'm starting.
Microscopic, if you can do it, nothing wrong. Yeah, nothing wrong because microscope can measure that. But no, what you do is microscope. That's an affair. As you said, this is a very complicated job. I just said this. You're ready to do. Therefore, you should do Epitympanum with no. Because the first person who is you make better. And then propagating your demonstration operation using everything. And you told us we are sitting and seeing now. They have very techniques and they are great people. We can do the same thing in better results.
I think I've gotten a better burr now. So it's progressing forward. Yes. Now I'm removing the periantral air cells.
Actually, there is the patent. There's a patent you see, put the saline.
Yes, it is already patent actually. See, if I already put saline here, sister? Yes.
Whatever he does, so already we are near the end now. That's what it means.
So aditus is quite patent. In fact, there is a thick bone here. Probably this could be the this thing also, the corner septum also. Probably here, that's the reason it is a very thick bone, or this could be the extension of the cortical bone itself. Okay, so if you notice, the antrum is somewhere more inside. We still have a few periantral air cells to remove, and we are, as we do, our direction of dissection is along the important structure. So the important structure superiorly is the tegmen here, and here is the posterior canal wall. These are two boundaries we don't want to violate. So we are going up till we remove this diploic bone and reach a hard bone again. If you can see a little more inside, I can already see one hard straight piece of bone. There is little bit of the spongy bone here, which we will remove now. So I'm going from one known landmark to another landmark. So I'm entering a big air cell. This is probably my mastoid antrum, but it is still not confirmed. What tells me and what makes me decide that yes, this is the antrum is actually the lateral semicircular canal. Can everybody see an ivory bone inside? Pick, please. Yes, this is my lateral semicircular canal. Let me extend it, remove a little bit of the bony projections. I may be able to show you and delineate this better. Yes, doctor. Yes. Yes. Absolutely. So today that is the Takahashi's principle. So according to the Takahashi's principle, it is the midlayer mucosa which is important. So if you do a big cortical mastoidectomy and you don't find anything, and you're actually clearing off the midlayer mucosa also. So just the presence of the patency is good enough for us to tell that yes, the mastoid antrum is patent, or many a times even a CT scan may suffice. You don't have to open the mastoid, look, and then tell yes, it is patent. If the CT scan has given us a good enough this thing, you need not do a cortical mastoidectomy also in today's time. Yes, sir.
When I was a postgraduate and attending molecular podcast,
Yes, sir.
before the question I asked, okay, when you are opening, suddenly you see that everything is there, why don't you stop? When you know what the answer, the whole crowd the answer, why are you lazy? The computer physical research. That was the answer they gave. But today's ideas are changing.
Yes, sir.
Now the ideas are changing because now they know the importance of master area. When the recipe is very quick, it will give they understand and they contribute. So the ideas keep coming.
That's there. You're right.
The
Okay.
recipe that's why your it is like if the air cells are diseased, then you have to remove. Even if there is patency, to remove the disease, you have to complete the job. But if you treat the cancer air cells are healthy and the act is already patent, then you can stop. Yeah. Today in there is a controversy that opening the mastoid mechanism are patency of the and from why you have to get patent because so many times I have in a bilateral TSL patient, I have opened mastoid antrum in the same patient in 1 year. The other side I have not opened. I'm getting the same result. I'm in consultation. I have already done mastoidectomy. I think I have taken. Then patency, but see the graph uptake percent. The graph uptake doesn't depend on the patent. Yeah, there's something called post patency or partial patency. So what he got me the three patents. Sometimes everybody is the get of layer and we can get a post patency. And sometimes slow patency, partial patency, all these things are there. I can think for endoscopic care surgeon. So why to do the mastoidectomy? You do the proper material work and fix the system and clean there and receive the only by having this double. If you assume by everything is taken, don't really get the mastoid. Is that correct? So that is just the canal, which is now used, which is in the discussion and manual, which is proposed to the editor. So the intent was to be defined, so what is, we want to start the law of the too much technology enough. So this is what doesn't say, this is how the editor is
Edition are already there.
so rejecting into a air place is tunnel and it is coming back. This is proud guys.
I'm actually trying to remove all the cortical bones.
Okay, clear.
Yes, sir.
We usually need to remove the underside and the dual state before we try to search for the answer. So what do you suggest? Should we first delete the place and go to the anthem or find the anthem first?
I always actually try and find the antrum first. I want to know one of my landmarks. As we are doing this process, we are actually slowly delineating the sinus plate, the dural plate first, and then if needed, we can extend and go up till the sinus plate also, sir. Would you recommend first delineating this thing?
And then I see, now you can see the various canal, the anatomy of the various canal which is still intact, and see the lateral system in the L-positive, which even though you are trying to you know that you are not going to damage the lateral system. Below that is the gentleman. And later, we'll show you the account.
What is the take if we encounter the corner septum?
So the corner septum is basically a very hard piece of bone, which is the persistent petrosquamous suture line. So the suture line is actually, it enters, there's a petrous and squamous bone. That plate of bone extends up till the squamous bone. So they say it is dehiscent at the squamous portion here. So it is easier to enter from the superior aspect and then drill it out all the way down. So if you're not seeing the lateral semicircular canal, then that means you're encountering the corner septum, and you will have to remove that piece of bone to achieve the editus patency. So I'm removing all these projecting pieces of bone, and if you notice, I'm always using the side of my burr to do all the cutting work. I'm not using the tip of it, but I'm using mostly the side of my burr. And we are also supposed to use the largest size burr. Unfortunately, I couldn't find a very sharp burr today, so that's the reason I'm still going around with this burr, but it is working for me.
And if you extend attic also?
Sorry, sir?
You want to extend attic?
Attic also I will extend, sir.
Until all of it.
Yes, sir. I'm trying to delineate up till the tip.
Yes, I just want to add one point.
Yes, sir.
Delineation of technique, because I remember once I worked with Dr. Vivian for 2 years. So, sir, one day, both sessions and I was working with him. He asked to tell me what is the landmarks for opening the master. And I said, maximum planning, and we really improved me for that. So the reason is because we felt, we felt that you always identify the middle bottom plate, the segment plate and follow it. So now, what I tell generally when I'm doing master and we are teaching them all, I say don't try to go into the angle. The angle stop it. What you do is because you always reduce the angle by softening the edges of the cavity. So you don't have to really go looking for the segment plate, but you know that as the nose changes, where is your segment plate? Once you identify the segment plate, you always say below. Okay, and you also know that anteriorly as you go, the segment plate will cross out. That is one thing. The second point is we discussed about why we have to open the mastoid. Now, the cases now we are doing mastoidectomy are those where we have the real pathology, like adult media, interaction, topic to destiny, definitely you know the mastoid. So when you open the mastoid, you should get enough space. Suppose you have a blockage of the meter to protect the ventilation, top tissue, and all that. So once you delineate the segment, you know, sometimes you have a very anterior sigmoid sinus, a very chaotic mastoid. Once you delineate all these cells, then you will be able to detect. So even if I don't get anticipated, I always I do railroading, or sometimes you know one of the research we can do is you can remove the input and you type it. So for doing all this, you will need space that can only be done when you nicely delineate the segment. But don't go looking for it unless because then become like mental into the segment and the doer.
So you can always scale.
There's no limit. I mean, you see, that's what. If at all it's a simple yourself and then there is a any sort of thing. That I would like to open access. But I definitely not unnecessarily till the steps like this moment. But generally, segment you will be best designated because you are properly around and you know the canal. So segment at least will be designated. I think you would say of this. I also, as Vivek was a good technique because the practical teaching is going through the measurement science. Okay, that is true when we get the expected anatomy like normally situated segment or so normally situated kind of. But in cases where there is a low-lying segment or anterior-situated kind of space, then it will be difficult to enter the working way. So in those cases also, as Dr. Anand advised, in that way, that was in those cases. In those cases, I only follow the text. Otherwise, it's a classical case because I'm doing the phone being system for one cases. I know the matter area system, the state of matter. So in the regular way only I go because it's faster. Okay. The discussion is not really the question what you are doing and doing. Once you find it, I accidentally open up the door and you start making the creation. So then you have start to listen to the after the beginning, you are now wired, your finance, your social class, and you start knowledge and find what to do for it. So you can see the dedication, but we should not fail the goal. You can increase the concept. But even with a good landmark to reach your next perception challenge, you don't reach that. The top of the family of the Bolivia announcement is not better to live and academically looking how the announcement of the study, that is the discussion elsewhere. However, in the context, you can see how much you can produce an accurate study. Earlier than we were giving studies to the then special technology to be out of we were going to just control the situation and come out. And these using is not what is the case, we were getting better in application because it is why we, I mean, added this point and we wanted to, we are having this nice discussion during this morning. So, I mean, it's just something like, and just, we are all trying to recollect the point, just, you know, just enter the question. So, as well said, one thing you could never do in like, you have a program or a case program and you decide on one thing you never do is the policy. You could have reached the dividend, you could have reached the payment, then it's okay, you want to make it part. Yeah, the Cochlear, it happens quite often, it's not a problem at one point. But those, the real thing is not the real problem, because experience, we can experience, but I always would struggle with seriously, and what happens is even if you feel, sometimes you see or done other thing, you may get a case of pain. Yes. Case of pain, so that is very important. You can see it now generally. Now, for example, why I was just for a week back, I did a very complicated real case where there was a transporting process. A complicated because I wanted to elaborate and all that all language, multimedia paper. So there I didn't think of multiple and cluster where I even made it.
That is different. I know I'll be doing this wide approach and closing the whole ectotic canal and control petrosectomy and all that, put up on bad level. That is okay. And I have been as but a lot of this always of put. So I handle CSO. But I have to tell you one incident where I was offering a already in the evening. That was it was very strange finding with the patient coming with the retraction moment posteriorly. So he had followed up with the retraction and posteriorly. So I had done a CT with a very reputed radiologist, and he reported it as a pulsatome. I mean, because 9 out of 10 times is all correct and these findings are very good. So she and that lady had to travel to hospital or something, so young lady. So I had prepared in my center that I would do a string tag and I was upward for a pulsatome surgery, which I would like because it is static and all that. But when I opened the mastoid, I did not have any pulsatome. That is one thing. And the retraction pocket. So basically, he had Tympanoplasty. Okay. So I was planning to do a static pocket for Epitympanum. So I wanted to do mastoidectomy like this, and then I do Epitympanum. So when I was doing Epitympanum, as I said, no, it was a heat, and I want to do it on some time. So I use sharp burn. Yes. I was already activated. I was just I was the injury. So the sharp burn very, very theoretic math. Very theoretic. Everything was collected on my master. Very narrow and he had a research. I had to do it with the so when I just that moment when I was pressing on the thread, I just hit and I got came from the segment. If I very fast, I will multi-layer using with the flash, fascia, bone pattern, and acid surgery. There was no even any problem at all. Just precautionary, I put on a week of time. I put on a week of time on. And but why look at those other? I mean, I never think like police reported a very good radiologist, very nice surgeon, in fact. And it was totally different. And such a small master accident. So in these cases, that is why it says that identifying that doing the work identifying technical value. I often I see this anterior is not finding. Cases in a theoretic mastoid. Sometimes I think when some of my juniors start, they struggle to accept the outcome. And then when you go, the way you start building the protein economic and generating the technique, you understand that you will create enough space for you to go to the next step. One looks almost like not positive, you can it looks like drilling and delineating is important. As you go anterior, this is the over here. So that is actually not because of my mistakes. So I just feel right to do anti-Tympanoplasty part and so it doesn't matter if you will not do anything. So if at all it happens, if you have position for correct, you will in a safe place. I mean that is definitely your you should know. See, when you are identifying the insertion, you know how to drill. You should drill from median to line. See, states as identified, you have a lens there. Go for median. Don't angulate your bird towards the section. That is what happens. The bird is not angulated like this. Sometimes when you're building on the lens, also I prefer those short lenses. If you are using a long bird, the very thin short bird, and then suddenly, you might lose control at those exits. Sometimes you have to understand there is limit also. So when you reduce the speed of the bird. Okay, you use a high speed bird and then whenever the bird, whatever you practice the exit, sometimes the bird just like that. So that you have to use that. I have to respect. So I always, whenever I do a technical area, I don't tell you the use of maximum speed in discussing. As soon as I come near certain critical areas, or even doing canaloplasty, and on the stage, I reduce the speed to one. So that gives you better control. And probably shorter than gives you better control.
So what we are doing now is actually thinning the posterior canal wall on one side and moving more anteriorly between the tegmen on one side and the posterior canal on the other side, removing the cortical bone outside, and also as we go inside, going more deeper in the epitympanic area. These are actually the zygomatic air cells we are removing and the periantral air cells we are removing. Saline. So how much to drill is basically until the first this thing the basic bottom line is still wherever the disease takes us. But if you're doing it for a routine mastoidectomy, I want to be able to see the incus here.
Yes.
Okay. So if you notice, there's a more curvature of bone here, and I've still left that bone because I still want to go for a smaller burr before I actually go into that depth. Okay, I want to remove all the outer portion of the bone so that my visibility to that area becomes better, and for my approach I have enough space.
At this point, when you decide to drill for medial to lateral?
Medial to lateral. The very last bit actually. Okay. So I don't want to slip my burr inside. So this is what I call as the equator of the burr. The equator of the burr should never go deeper. So I can demonstrate with a smaller burr.
You're already seeing an incus.
Yes, shadow there. Yes.
So the whole idea would be this would be post-epitympanum. You drill till you identify the input of malleable current. Sometimes we call that as a Pratt sign also. So you can drill till you identify the input of malleable current.
The Intratympanic is a good way to clear the disease and complete
Salinaki. So in fact, with the shadow of the incus I'm already able to see. Is Sister Salinaki? So when sister is instilling saline, you can already see the shadow there. Can you appreciate that? Is it visible?
It's visible.
Yes.
Nicely visible now.
Yeah, it's very nicely visible in the film of saline there. So what we'll do, I just, Saku sister, I know the incus is right there. See, this is the proximal end of the burr. This is the distal end of the burr. This is distal, and what I'm showing with the suction is the proximal end. Equator is somewhere here. I don't want to put my burr here and start drilling like this. I want to keep the equator of the burr under vision. By doing this, if I constantly, take this under irrigation, if I'm not entering, the chances of us touching it is almost nil. But in case, if you actually put your burr underneath like this, then the chances of injury to the incus is higher. So that is something to be avoided. From here onwards, you could do like Dr. Uday was suggesting. So you could come from medial to lateral.
You can also appreciate the shape. No, it's almost like a kidney shape or the kidney plate shape. So that is even in a cortical if you do.
That.
So, if you ask me, of the cases when I have decided to do mastoidectomy, all there's quite a lot of disease in the mastoid. Invariably, I would end up with at least post-epitympanum. Almost all cases. So that is when my identification of segment becomes important. When you don't have to identify through the lens, identify when you identify one set, you know to stay there.
Okay. Is the incus well delineated? Yes, up till the fossa incutis, I could still remove a little bit of bone to delineate it better. Drill, please.
Can you show the superior equidal ligament?
It's actually seen here. So.
Hello, Dr. Uday. Can you hear me?
Yes, sir.
Yeah, you can see now where you are concentrate on the space.
It's not centered, not centered.
See the way you are now.
Yeah.
Delegate, you please see now. Now the lateral femur canal is in view. Incus is in view. Or genu is in view. Can you see the genu? Second genu of the facial canal?
Yes, sir. Yes, sir.
So they're all there visible now. Okay, now see the position of the various tunnel. Yes, isn't it same?
Way anterior. Way anterior.
Yeah, very anterior. And you see within the thickness of the post-canal wall, the various channel exists. So that is the reason it is quite a safe technique. Okay? Even though it is done blindly, using the proper guide like hand perforator, it can be safely done. It's convincing, isn't it?
Yes, sir.
Okay.
The case is likely sitting the posterior canal now. From medial to lateral, that is your still better idea. Yeah. The good thing important is that don't once it touch the lateral canal wall, of course not touch the axial. Especially in a ossicle which is in continuity.
So important not to make contact with the ossicle using a burr. It can cause a sensorineural loss. So yeah, the one thing about the tegmen is never it is in a straight line actually. So many a times you may have a lot of these projections. You may have to straighten it out, and tegmen may go lower down at some areas and it may be higher up in the other areas. Just because you had a low-lying tegmen at one area doesn't mean that it will be low-lying all across.
And here you can see the superior ligament, manual
Inferior ligament.
ligament.
Can you see that?
From the anterior manual ligament earlier, now we can see the superior inferior ligament. Can you see that?
This one.
Yes, sir. Yeah.
Okay. So now we'll actually, the next step is actually I want to thin down the posterior canal wall and thin it appropriately and go more medially. I will be starting to do the post-tympanotomy technique or the facial recess approach now. Okay? Change ಮಾಡಿದ್ರೆ 25 minutes ಇದೆ. Okay. The next is
So for post-tympanotomy, all the perifacial hair cells, retrofacial hair cells have to be removed, and the posterior canal wall has to be thinned out completely, and then blue lining of the facial canal has to be done before actually opening into the facial canal.
So to start off with the approach to the post-tympanotomy or the facial recess approach, we first begin with an end-on view. We want to keep the view of the external canal. We want to keep the view in the mastoid also. We want to have a view of both the external canal as well as the mastoid and keep thinning so you know the approximate thickness of the posterior canal wall. As we go more medially, we will change the view. I will show you. If you see, my direction of dissection has changed. I am going in line with the external auditory canal. I'm still using a cutting burr. One of the landmarks is our fear is that we should not go through the facial nerve, correct? So the lateral semicircular canal is a good guide to tell us the level of the facial nerve. So facial nerve is generally more medial to the lateral semicircular canal and inferior to the lateral semicircular canal. So that way I first have to go a little more deeper to reach up till the level of the lateral canal. I'm removing all the cancellous bone. So we'll very soon start encountering the perifacial hair cells. Okay. Once we are here, We will go to something called as an end phase view now. Okay, so in the end phase view, I'm actually tilting my bone in like the patient's head and looking only at the posterior wall.
What stage you will convert it to diamond birth stage?
Probably now. I would prefer a little more exposure for the end phase view. I'll probably increase my exposure here.
Yeah.
ಇರ್ಬೇಕು ಇಟ್ಕೊಂಡಿರಿ ಒಂಚೂರು ನನ್ನ ಕಡೆ
You can see the change in the sound.
tone, yeah.
Change in the sound when the bell is running on the sinus plate. Can delegate appreciate that?
If you give the tone,
So when that calculate factor, there is a sinus plate there.
And diamond bar, please.
One should clearly differentiate what is mastoid exploration and what is cortical mastoidectomy. If the mastoid exploration is done only for to check the antiquity
Smart.
and to see the antrum, whether there is disease in the antrum like cholestoma, tympanostotic patches, or cholesterol granuloma, as Dr. Uday said. So if such things are not there,
Change
then
ಮಾಡಬೇಡಿ
mastoid exploration is sufficient.
ನೀವು ಇದು ಮಾಡಬೇಡಿ
But if there is a disease, then one has to completely remove all the ears in the system, and that becomes cortical mastoid. So I see people interchanging the words cortical mastoidectomy and mastoid exploration. Majority of the time, Dr. Balu, what we do is mastoid exploration, not cortical mastoidectomy. Isn't it?
with the control where mastoidectomy,
Yeah.
the connections with the mastoid, we let you
coming back.
here. The library you can really as the mastoidectomy, mastoidectomy is also required or not.
Yeah. In fact, whether cortical mastoidectomy is required or not, also to see whether it based on the findings of the mastoid exploration. Isn't it?
Yes.
So,
So, if you see Dr. Sayed is actually running his guidance for parallel to the whole situation, not perpendicular. And lot of medications is being used because it's a guidance, more things can use. Isn't it?
there is something coming in view here. ಇದು ಕೊಡಿ pick ಕೊಡಿ.
See that the cortical bone is coming
If-
into view.
If you see, there is some a line I can see here. This is probably the chorda canal, but let us see.
Yeah.
Is it centered?
Yeah.
So at this point of time, we need to make long cuts, long strokes with a burr and something parallel to the facial nerve. It's very important to actually, imagine the facial nerve at this point. There are some clues to this. I think it's good we discuss it at this point. Facial nerve is normally, this is the lateral semicircular canal. It is more anteriorly and inferior to the lateral semicircular canal. we are able to see the incus here. Incus points towards the facial nerve, and it is said that it bisects the facial recess. So facial recess is the point through which we are actually entering into the middle ear. So basically the whole exercise now is to enter the middle ear through a safe space to either clear the disease in a combined approach tympanoplasty or to insert our electrode in the cochlear implant. So our boundary is posteriorly we have the facial nerve, anteriorly we have the chorda there. So superiorly we have the buttress of the incus or the fossa incudis, and this forms an inverted triangle with the wider base here and the apex here. So through this inverted triangle we gain access into the middle ear to be able to put our implant. So to do this we have to go, make vertical strokes, enter through this area, this being the wider portion. It is easier to enter the middle ear at this point, but we always want to leave a small piece of bone or ledge of bone here, which is called the incus buttress, in the process of doing this. By doing this, you are ensuring the safety of the ossicle. So we are still using a large burr. Okay, it is about a 3 mm burr, diamond burr, but the strokes are made parallel to the facial nerve. So with every stroke, important to read the bone, see if there is any change in the color.
And sometimes at this stage, we can see one cell called Herald cell. Herald cell. If the cell is in the posterior, even before the posterior Epitympanum, this cell will say hello to the patient. Okay. If the Herald cell is there, then we can follow the Herald cell and then we take it to the nucleus. That is the importance of this cell, Herald cell. Let us see if Herald cell is there.
And in some soft tissue there. Switch over to a smaller burr system. I see some soft tissue there. We have still not, let's not open it. So it's very important to change to appropriate burr size as we go. Continue the same process. Saline, please. Lot of saline. So lot of saline irrigation needs to happen. I see some soft tissue coming into view. That is probably that could be the facial canal, but let us go ahead with caution. It is okay to actually open the facial canal. It's just not okay to not identify it. Even if the facial nerve is exposed, there is no problem. And smaller suction, please. So this is the point where actually you should smaller suction, just a 18 or 16. Appropriate size suction and burr are very important here.
And you can see the color change actually that where the shows that there's a air deeper lips. So we are almost
so yeah, probably there's a thin shelf of bone there.
Yeah, open.
Yes, it's already open there.
But you can see the reflex happening. Can you see that?
Yeah. Maybe a smaller burr system.
Isn't it?
Yeah.
Dr. Balu,
Yes.
I heard one of the senior professors telling that
Small.
after mastoid exploration, he sees that
Ashta
he
small.
doesn't get occupancy.
Yeah.
Then he will actually get you open the facial recess to get the patency from the mastoid.
Same.
ಇದಕ್ಕಿಂತ ಚಿಕ್ಕದಿಲ್ಲ. Is that advisable? Just to acquire patency, should we do the
Facial research.
Yeah.
No, I think what Dr. Udayam mentioned was perfect. I think one must be not just to achieve the research the distance, the pole of the interest and it will take the disease which is underneath the interest. Could be the block, then we can report with the type 2 or we can remodification of the interest and we can do the plastic.
So should we do? We just get the should we do this
ಇದಕ್ಕಿಂತ
Just removing the part of the disease goes clear.
not to get active patency.
Yeah, sometimes you may get a little better
ಬಟ್ ಸೇಮ್ ಇದೆಯಾ ಅದು
result.
ಅದು ಇದು ಸೇಮ್ ನೋಡಿ
You can put it back.
2.3.
In case if you're not achieving good patency or
ಇದಕ್ಕಿಂತ 1.5 ಹಂಗೆ
ಇಲ್ಲ.
ಇಲ್ಲ ಓಕೆ ಸ್ವಲ್ಪ ಕಮ್ಮಿ ಸಿಸ್ಟಮ್
So now we are writing the facial.
I'm widening the facial recess now that
So now you are writing anterior. How far you have to go anterior?
Yeah.
the anterior most limit will be the this thing actually annulus, but we don't have to go all the way up till the annulus, and in fact posterior widening will help us more because this approach I'll remove the soft tissue. Our interest is actually the round window, to locate the round window through this opening. Microforceps please. So generally a posterior extension is what is more necessary than an anterior extension, but any widening in this area will improve the space and visibility for the surgeon. If you notice, this is actually the facial nerve. Okay, and we have opened at one area, we have unopened this thing. We have not damaged the facial nerve, but we have uncovered the facial nerve. The sheath is still intact. So if you can identify the facial nerve, some people routinely do that as a necessary step in every case of theirs, but it is not always necessary maybe. Now with this opening, I'm already able to see the IS joint.
Yeah.
So the pick please, pick. Yeah. So this is the long process of the incus, the lenticular process with the attachment to the stapes. Okay, this is the stapes and this is the incudostapedial joint. And if I move my microscope, we can see the cochleostomy or the extended round window opening.
Yeah. Now it's clear.
The extended round window, through this we are able to see. Okay, I can now extend my dissections a little more inferiorly up till the cordofacial angle. Actually you can see the chorda is here and the facial nerve is here, so I am still at liberty to remove a lot of bone here and able to access better. So that will give me more access to proceed inferiorly and give me space for insertion of the electrode.
So this is actually called extended facial recess. So extended facial recess is extending downwards, and in fact he may even sacrifice the chorda tympani nerve and still go downwards. Dr. Balu.
Yes.
And that can become extended facial recess until hypotympanic is visible.
Okay.
And this extended facial recess may be necessary procedure for glomus tympanicum. Dr. Uday, you feel the extended facial recess is sometimes enough for glomus tympanicum, or you want to do an open cavity for glomus tympanicum? As we saw recently in one of the cases of extension of glomus tympanicum, it was better to do an open cavity. What is your take on this?
Extended facial is definitely in the literature. It is mentioned for a Grommet Tiffany from a different mastoid.
Yeah.
But I mean, probably we're talking about different mastoid.
Yeah.
But many a times what happens is the pupil is going under the facial of the facial canal. Like as we saw in the recent case also we did.
Yeah.
So I think canal wall down is a safer procedure anyway. And these Grommet pupils are quite notorious with the amount of bleeding that might impair your vision. So, because for me, Epitympanc control is very important.
Okay.
So,
Now, hello.
I think which literature extended facial reports for the global Temporal master, I think still in the literature. I don't know what many of them really practice.
honestly, sir, in my, I've never done it. I mean, I've never.
Exactly. So extended facial. In one indication, extended facial research may be helpful, Dr. Balu. Yes. That is traumatic facial So where you want to
Electrode
to decouple the facial nerve.
Okay.
So that time, extended facial research may be still beneficial.
Maybe in some cholesteromas, sir. But very rarely, cholesteromas are mostly superior and going down posteriorly. Epitympanc reaching them very rarely.
What about
So,
cat compression, combined nervous tympanoplasty for cholesteromas? The extended facial research may help, isn't it? If cholesterol is going downward. And we want to preserve the entire
18 number section, please. So we'll proceed further. Now that we have a good facial recess, I think a wide enough opening, what we'll do is we'll probably make the opening a little more fine. We'll extend it slightly more inferiorly. That will give me a very straight path for and easy path for electrode insertion. Okay. So Anshur Hatra Tawali. Yes, thank you. So maybe at this point, what I realize is if at all my burr shaft is actually touching the nerve here. So I want to use a shaft which is much more thinner, and that will prevent any injury. But let me just see. Okay. Okay. I think that's good. Flush system. Yes. Okay, now we'll go ahead with the insertion. We have a contour electrode like we said. So give me the sizing tool. Forceps. Regular forceps, please. Yes, not took.
So for the delegates, please watch the insertion of this dummy electrode.
So
Since this dummy electrode is very expensive and very delicate, we may not be in a position to give this to the delegates for practice purposes. Just watch this. We will clearly show you now.
So this is called the sizing tool. This is the kind of opening we need to have to snugly fit the electrode. So this sizing is, if you notice, the sizing tool is, I'm leaving it, and it is, I'm not having to hold it at all. It is sitting exactly in position. So I know this is the appropriate size opening for my electrode to go inside. Okay.
Okay.
So let us remove the sizing tool now.
This comes with the Cochlear implant kit. Okay. Isn't it?
Yes, sir. This comes as a standard this thing in the implant kit. Mind you, this electrode what I'm using has been used a couple of times before also. So I think it has lost its this thing a little. There is something called as the electrode introducer. So this is how it looks. Give me a non-tooth forceps. Okay, there is a flange for us to hold the electrode introducer. Keeping this in view, what we'll do next. Good. I have an electrode holding forceps. Just a minute, I'm showing you. So we will. Is it in view? Okay. It's a very soft tip introducer basically. So I've inserted the electrode into the introducer. If you see, there are 2 points. This is one white mark and this is the other white mark. Please let me know if I'm out of field.
Yeah, you can see that.
This is one white mark and this is the other one. This one needs to go up till this point. This means it is completely inserted actually. Okay. So what we'll do is we'll further pull it inside.
Is it clear, Balu?
Yes, we can see the pulling of the electrode. Now it is completely.
It's completely inside.
Yes.
Now what I will show outside in a
But
step.
it will be the implant kit. It will be in this loaded state.
Yes, it will be in this loaded
Loaded
state.
state. Okay. Balu,
Okay.
is it clear? It will be in the loaded state.
And once we are inside, what I will do is align this mark with this one, and then we would have inserted completely. I'll show it once on the outside, so we have a clear idea as to what is happening on the inside. So I'm actually pushing, stabilize my left hand,
Yes.
and pushing only the electrode that will go inside the cochlea like this.
Yes.
And once I'm aligned like this, that means I've fully inserted. I stabilize my electrode from now on and start pulling the introducer outside.
Right.
So this will be the step I will be performing there. Okay, now I will reload my electrode inside.
These are very modular electrodes.
Okay.
It will have the modulus. And it's supposed to improve the hearing better than the straight electrodes. Because all the neuronal elements in the cochlea are towards the modulus, isn't it?
Yeah.
So it is how I remember. Okay, it is slightly different for every electrode and the make of the electrode. Suction, please.
At this stage in the light surgery, we can use the hyaluronate, that is the helon drops or dexamethasone drops into the scalar tympanic.
Okay, so how we remember is this pick, please. Electrode holding forceps, anything. The flange of the introducer, which I am holding, should always face the lateral semicircular canal.
Okay.
Okay, that way the orientation of the electrodes is appropriate.
Okay.
Okay, we should not place it the opposite side. Then it's because this is a contour electrode.
Yeah.
It is supposed to hug the modulus.
Is that point clear
Yes.
to everybody?
So
It is pointing towards the lateral semicircular canal.
canal.
See that?
Okay, now I'm actually leaving it there.
Yeah.
Can you observe this?
Yes.
I've left it there.
Okay.
Now I'll focus in such a way that everybody is able to see. I will rehold. Okay, now start introducing my electrode.
Yes, it is reaching the mark now.
Yes, it is going. We have to do this very slowly.
So, okay.
And your left hand is retracting, is it?
No, I'm not yet started.
Okay. Yeah.
Now I'm
Now.
completely aligned to that point. After this point, my right hand is stabilized
Yes.
and I'm pulling off the introducer.
Yes.
Okay,
Yeah.
introducer.
So obviously this electrode cannot be used by the Varia technique.
Correct.
That's the reason post-tympanectomy only. Some electrodes are made only for post-tympanectomy.
Now, if we notice, there are 3 marks there at the end. Is it visible?
Yeah.
Okay. At least they say one mark
One mark
should have gone inside. So you can realign it, maybe push it little more inside and adjust it. Oh, this is appropriate. We don't want to be pushing it too much inside because this is contour electrode. If we try to manipulate it too much, it will not sit along the modulus anymore. Hmm?
And because this is the round window approach, extended round window approach, we are 100% sure that this is in the scala tympanic, not in the hypotympanic air cell. Isn't it, Dr. Balu? Yes, yes. Otherwise, you have to confirm at this stage, you have to confirm by taking an X-ray, intraoperative. Correct. Or by doing NRT. Yeah. Most of the neural response telemetry or neural response telemetry. Yes. Okay.
So this is the introduction of the cochlear implant through the posterior tympanotomy, and we've used a contour electrode for this.
And while you want to remove this dummy electrode, you just want to pull it out, or you want to put the inserter and then pull it out?
No, we can just pull it out. Yeah. So I'm pulling off the electrode. We can see as the electrode comes out. See, there is no deformity of the electrode. It is coming out straight without any this thing. That means to say, even inside, it has not coiled, and it had gone all along the modulus. Thing is, many a times, the tendency is to push it more inside, trying to feel that maybe if it is pushed more inside, it goes up till the apex of the cochlea, but it is absolutely not necessary because we are not stimulating the apex. It's only the basal and the mid turns of the cochlea which is stimulated.
I think Dr. Uday will be showing tomorrow in the cochlear drill out how the basal turn, middle turn, they all go, isn't it? Dr. Uday, you're there?
Suction, please. So, moving to the last bit of our dissection, we'll delineate the facial nerve and end it with facial nerve decompression. Okay. So now I'm extending my incision much lower down. Okay, and I'm actually sacrificing the chorda here. Yes, till the chorda facial angle. By doing this, you can see the chorda actually is moving there in the mid layer. So the idea, see, the chorda is moving when I doing that. The idea is that I want more access. So maybe in a procedure which involves like Dr. Uday Banu said, mastoid glomus tumor, tympanomastoid glomus tumor may require this approach. I'm also uncovering the entire mastoid segment of the facial nerve.
Each step should be completely done. Then only it will allow the next step to be more comfortable. What I mean to say is that after this facial resistance approach, if you want to do facial nerve decompression, so this approach should be done properly, then only we can do a proper facial nerve decompression. And if I have to show the labyrinthectomy, then all these steps should be done perfectly. Then labyrinthectomy will be easier.
Take a good test. In case dislocate
So after this the last procedure Grace is going to demonstrate, that is facial nerve decompression. Okay, this procedure is done especially for traumatic facial nerve palsies, road traffic accidents and all these things. Okay. So after this, I will be taking over and I will be showing you the remaining procedure, and I may take another 20 minutes. Okay, I think by 1:30 we should be finishing and we'll be going for lunch. And our scheduled time for delegation is at 2 o'clock. So we can have a quick lunch at 2 o'clock. The delegates will, they have already been assigned to the stations. They can occupy the stations. They can wear the disposable gowns. and they can be ready. I think temporal bones are also readily fixed onto the stand so that we will not. Okay, they have to just fix the temporal bone and they have to start.
So at this point, I want to just interrupt because we'll just proceed with the dissection. You can see the varia tunnel.
Yeah.
This is the varia tunnel. This is our level of the facial nerve. There's probably about 2.5 millimeters of distance between the varia tunnel and the facial nerve. So just to say that varia is also a safe technique. Inductively, na? Yeah, the in fossa incudus, you want it intact?
Yeah.
Ah. Hmm. Hmm. So far yeah.
Till now, all the techniques has been shown with the intact canal wall.
Yeah.
The majority of our techniques, we can do with intact canal wall.
And with the incus also in situ here till now. Now I am thinning out the buttress and I will probably disarticulate the incudostapedial joint because I don't want to transmit any forces inside. So the Kodi, right angle pick. This is a 18 number suction. Okay, no problem.
Yeah. Little bit of
Centering, okay, yes.
Yeah, better. Yes.
Is it okay, sir?
Yes.
So this is the long process. This is the lenticular process. Change my buddy question.
Yeah.
So slightly below the lenticular process. If I move, you can see this point. This is the junction. This is the head of the stapes and the lenticular process. That's the IS joint.
Yes.
Just to insert the pick, it will automatically disarticulate. Okay.
And this should be done with intact state.
Intact stapedius
Tendon, yes.
Yes. You should not cut the stapedius tendon before
Then do that.
you do this. Yes.
And I'm slightly pulling it up,
Yeah.
and I would probably want to remove it from the externotary canal.
Okay.
Hmm?
So always better to remove the incus from the
Externotary canal, sir. ಇದು ಮಾಡಿ ಹಿಂಗೆ ಇಟ್ಕೊಳ್ಳಿ ಬಟ್ಟೆ ಇಡಿ ಇನ್ನ ಟಿಲ್ಟ್ ಕೊಡಿ okay, is it in view?
Yeah, no, they need to be
Center, okay.
Yeah, now it's okay. Now we can see the
Incus.
coming out.
Now you can use a micro forceps.
Yeah.
Micro forceps, please. The ligament is held quite strong. Slight movement and
So the one is causing visible.
little correct, sir. Yeah. Normally it is not this difficult also. This is the incus. It could be separate again. That can be used for our ossiculoplasty, bidi brother. Take it bidi na. Now we'll go back. We'll trace our facial nerve. So we have many points which help us locate the facial nerve. Take it. So I'll probably use a drill and maybe expose the this area, epitympanic area. You can also remove this buttress at this point. I'm still keeping the canal wall intact. I'm only removing the buttress. Sorry, I think I buttonholed a little. Okay.
So now we can see the head of the malleus is seen.
Head of the malleus is seen, including the head of the stapes is seen. It could pick please. Now this is just to orient. This is the stapes, the superstructure. Anterior crura I can see. Posterior crura is still not visible. And this is the horizontal segment of the facial nerve. I want you to appreciate the relation. This is the lateral semicircular canal. It's antero-inferiorly to the lateral semicircular canal. It is posterior superior to the oval window. So this is our facial nerve. This here is, let me slightly change. Yeah, this is the processus cochleariformis, and that is the just slightly posterior. Here is where the facial nerve, the first gene of the facial nerve is located. The genicate ganglion is present there, and from there the greater superficial petrosal nerve is given out, which proceeds anteriorly. Now, after the first geno, this is the tympanic segment of the facial nerve, and here somewhere is about the level of the second geno, which is the second turn of the facial nerve, and it takes the turn and becomes the vertical segment here. We have uncovered one portion of the facial nerve here. The facial canal is open here. So it proceeds downwards and it exits through the stylomastoid foramen. Inferiorly, I think what we could do, I'll show you now. Digastric ridge I will delineate, and we will trace it anteriorly. We'll remove this bone and we'll trace the digastric ridge or till the facial canal. Okay. Same Barcode. So I'll. You should be careful in life doing this step because the lateral semicircular canal is present immediately superior to it. Many a times in uncovering, a lot of times even the lateral canal is becoming thinner and thinner in the process of uncovering here. The dissection should happen in direction of the nerve. It's already sufficiently thin here. That's the second genu area. There is still a layer of bone which is covering. I would like to leave that layer as of now. We will trace the digastric ridge. I'll go to one magnification lower. So we'll quickly finish that and hand over to Pradeep sir. I'll use a cutting burr for this because that is also one of the landmarks to locate the facial nerve. Suction dotted.
Can I add a point?
Yes, sir.
So I think just now identification is actually one landmark which is very, very useful in always approach or even in mastoid, division, mastoids, and patient earlier when it comes to the patient is the diagnostic.
Yes, sir.
So, identification, I think those who start doing cortical management, the first thing they should do before they even go for this is identify the
Digastric. Yeah. Yes, sir.
so this is a bad situation. I'm expecting experience where like that is it. And you need what we have even done before we did the labyrinthectomy, identify the vertical segment of the patient now, the identify the identity. And then that's when we start doing the vertical because whatever we are doing the vertical segment.
Very true, sir. In fact, why I wanted to specifically show is because many a times we think, where exactly will the digastric ridge lead us to the facial nerve? It's only the superior aspect of the digastric ridge that will lead us. It's not the entire ridge. The superior aspect of the digastric muscle actually will lead us to the facial canal. The bone is surprisingly very hard today. Spite of it being a wet bone,
Also, just to put a point of opinion, I believe more they get confidence on patient and then as observing the process for the person we manage the patient. We would like to everything and to have the patient to be standard. I think that the boy will not a patient of the so you are telling me that this is what happens. And there are situations I can tell you, I mean, because experience there are situations where patient monitoring is very, very important. Because almost like a must have to recently take care that we have, but I care the patient also. And I think this is considered. So that you can have your patient monitoring that situation. You know, really, you don't have that luxury all the way to. Or never be. I told you the case of stenotic canal in Cortical. I was taking some time. I see your figure everything. Especially your Cochlear and the secondary and the semester is not fully subject. And the signal application, the expectations are opposite indication of the other way. And it is because the impatient view, I could identify very from beginning. So what I'm saying is, I always thought I is looking at more, that is the horizontal segment. The whole anatomy was seen. It was expected to be forced. So, and why in the case because not that we have done our but something from the strategy is during the cases, doctors sometimes you can never say never in medicine, never say impossible. So there will be situations where you will it will be like a Google or a Google, so you will have to really use all the landmarks which are available in the mastoid sometimes to identify the cases. So never be, I would say, definitely you be fasting, but not over
the card, yeah.
So you can read the origin of Kalda
no.
from the facial nerve That is so low. You see that? That is one of so low.
I think I should start using the diamond. Diamond, please. Sorry. Hello, Ossicular system. Yeah. I'm uncovering the facial nerve also inferiorly.
Actually, if state does its complete job, then it will be easy for today government to use for the tomorrow for the transportation technique. Facial or transportation.
You can see the chorda and the facial nerve now. Is it visible there?
Yeah.
Wait, one. I can magnify. It got it. Pick. So this is the chorda. This is the facial. So this is the chordofacial angle.
And you can see from the share, the facial nerve slightly moves anterior towards the external nerve lower down. So while doing canaloplasty, you see how much space is there from canal you show? How much space is there? Yeah, some people say while doing canaloplasty, we may damage the facial nerve because facial nerve turns anterior. But you see there's enough space.
There's so much space actually.
Yeah, enough space, so canaloplasty by itself may not reduce facial nerve. Isn't it?
Yes.
That's the facial trunk. Other than this is the chorda.
Yeah.
I think we have traced the. Yeah, that's the digastric ridge. Equally, drill, please. It's almost still the stylomastid foramen. The entire pathway, of course, you have not uncovered all that bone. Okay. So, okay. Okay. Take. So I will now decompress the facial nerve.
Yeah.
Not along the entire course inferiorly here though, but starting from here, we will decompress until the first geno level. Yeah. It got it? So to do this, we'll actually remove the head of the malleus. So, none correct. Get got. Malleus nipper, please. Okay. Now malleus nipper. Now focus the external canal.
Yes, you can see the malleus.
Yes, the neck of the malleus is where I want to snip and remove the head. This is a malleus nipper. So we will open it, introduce it here. It's quite tough. It can cut the bone.
Yes.
And I think one more cut will do. Okay. So still the attachment of the long process or the handle of malleus is intact.
Correct.
Okay, and we will remove, pick another recording system. Remove only the head of the malleus now. Let me see if the fracture is complete. I don't think it's complete. Malleus nipper again. Yes, yes. I'm sorry. I think there's a small attachment. Yeah, it's done. It's fractured. So since we have the mastoid also open, I'll extract it through this side. That's the head of the malleus. This gives us better view. Of the entire length of the facial nerve. We'll remove all this mucosa. Okay. Now, burr system. Small. Yeah, good. So, ಸ್ವಲ್ಪ ಸಣ್ಣ section. And yes, start.
So this is also an important step which you are doing in intact canal wall mastoidectomy for cholesteatoma. So exposing the intratympanic gastric level and snip off the head of the malleus to clear the cholesteatoma in that part, leaving the hand of the malleus intact to put your graft.
Yes, sir. A lot of bone dust is created because this is a bone. Especially in a cadaver, you'll get more bone dust, and even if it is a dry bone, it's even more. 16 number could be. Yeah. Important to choose the appropriate size suction, adequate irrigation. You can see I'm uncovering the facial canal. ಸ್ವಲ್ಪ ಕಮ್ಮಿ ಮಾಡಿ sister. They said that we have to do a 270-degree decompression of the nerve. See at some portions.
Dr. Balu,
Yes.
here we can talk something about what is barber phonics. Barber phonics. See, that is the direction of the birth keeps changing.
Yes.
In the traumatic facial palsy, for for posterior tympanotomy, decompression of the facial canal, there's something called forward poli. The direction of birth keeps changing. Okay. Anteriorly, when the birth is decompressing the horizontal canal, see that it says in go anterior.
Yeah.
So anteriorly, when it is decompressing, the facial canal, the direction of birth is anterior. That is to avoid damage to the stapes superstructure.
Okay.
Then as it comes to the second genu, the direction should be superior. That is to avoid damage to the lateral semicircular. And while coming to the vertical segment, the direction of birth should be posterior. That is to prevent damage to the cardiac implant. So this is the direction of the birth. It keeps changing, and this is called forward poli. P-O-L-I-N-G. And why the name came is in European countries, in front of barber shop, there is a stick which has a design on that. It is like a snake which is curving. Okay. So that's why it is called barber poli. Sometimes in the exam postgraduates.
So this is the entirety of the facial nerve. You can see some areas the sheath has been opened, and this is the tympanic segment of the facial nerve, and we can maybe go a millimeter more over here, and this is the tympanic segment. This is where the first genu is, and the second genu, the vertical segment of the facial nerve, and continuing downwards. We have not uncovered the bone extremely inferiorly, but most of the facial nerve has been uncovered. Okay, sir. I am handing over to Pradeep, sir.
Yeah, congrats, Dr. Shares, excellent and very good and very deeply done demonstrations of the basic and very important.
Thank you, sir.
Both to the cortical mastoidectomy, identifying the facial nerve and the facial decompression and Cochlear Tympanoplasty nowadays most all sought after for the cochlear implants. All these are very well delineated. Congratulations. Thank you.
Thank you. Thank you, Dr. Shreyas. So we are running 20 minutes late. Okay, but I think we can catch up later. And I'll be taking only 20 minutes more.
Okay.
So I'm expected to do the mid-level procedures like demonstration of endolymphatic sac. Then I will do how to do a posterior canal wall occlusion and triple canal wall occlusion, and also I will finish off with the labyrinthectomy. So that ends the procedures to be done today. Okay. After that we'll have a short inauguration, and then we'll have lunch, and then the dissectors can dissect. Okay. Now Shreyas has finished up to this. This is with intact canal wall. He has given me good, and now I will remove eccentrate other hair cells. For this I will use diamond burr, mid-size diamond burr, and remove the perilabyrinthine hair cells. See, till now, diamond burr. Yeah, that is coarse diamond. So I will be using the coarse diamond burr. So till now, what has happened is the hair cells have been eccentrated, but there are still some perilabyrinthine hair cells, and only lateral semicircular canal is visible till now. So we have to now start removing the. Yeah. So now I have to. Now I have to remove the perilabyrinthine hair cells. Yeah. I'm tilting the bone. Yeah. Is it clear now?
Yes, yes.
So I'll center.
Yes.
I'll center. Yeah. Now additional hair cells I have to remove. I'm using the coarse diamond burr.
Yes.
Perisinus hair cells I'll further remove because I'm expected to do now endolymphatic sac. And this is the only surgery which is done for Meniere's disease, and it is hearing preserving surgery. Okay? Done for intractable Meniere's disease, And these patients who have serviceable hearing, we don't want to destroy the hearing. And this is the surgery if they have intractable vertigo, especially not reducing with maximum medical treatment. Then we have to do endolymphatic sac decompression. We have done endolymphatic sac decompression. We are doing routinely for intractable vertigo patients, and it is giving good results, Dr. Balu. Only as far as vertigo is concerned, not for the hearing improvement, but it will not destroy the residual hearing as long as you don't injure the posterior canal, semicircular canal. So that is the one canal which can get injured while doing endolymphatic sac. So you should be very careful to remove the air cells around. Most of my procedure will be done by diamond and coarse diamond. These are coarse diamond. So I am removing all the air cells until I see a cortical bone, and that will be the postcranial fossa. And in a wet bone, we can see a blue lining that indicates the dura. So this is a well aerated mastoid. So I'll remove all the air cells. Is it clear till now? So while I am doing this, you can see the posterior semicircular canal is also coming into view. As I told, we should not accidentally open posterior semicircular canal while doing endolymphatic sac. So there is actually tegment breach is there, okay? Because I am lack of time, I'm doing little faster. That is the reason. So now the cortical bone is. See, you can see some amount of cortical bone is coming. That shows that we are near to. Can you see that? The regular diamond, regular diamond. Breaching the bone is not a problem, but we should not breach the dura. So the sinus plate here. Regular. ಸ್ವಲ್ಪ ಚಿಕ್ಕದು ಕೊಡು. Sharp. Now, so here you can see some amount of air cells now just superficial to the posterior fossa. So now, to identify the endolymphatic sac, you have to look at the anatomy now. So draw a imaginary line which runs toward the lateral semicircular canal, okay, and bisects the posterior semicircular canal and runs on the posterior fossa dura and to the sinus plate. The the endolymphatic sac lies below this line. The upper edge of the endolymphatic sac lies just below this line on the posterior fossa dura. Okay, not on the sinus plane, on the posterior fossa. So this is the area, isn't it? That is the area which I am going to open here. Here lies the here the bone. Okay, none correct. You already know the position of the facial nerve. Okay. So how to identify is, one is the Donaldson's line, which I just mentioned. The other way of identifying is a double-edged dura. Here actually this bone doesn't have the dura. Okay. This doesn't have the dura. You see here, it is already opened here. That doesn't have the dura. If dura is there, then you can see a double thickening of the dura. It will be double-edged, double-layered, and endolymphatic sac will be in this position. Can you see this? This portion, endolymphatic sac will be there because this is a Donaldson's line. It cuts the posterior semicircular canal and runs here on the posterior fossa dura, and here there is no dura, the posterior fossa dura. So this will be the position of the endolymphatic sac. Okay. Sometimes if this lateral sinus plate, if lateral sinus plate is anteriorly situated, we will not get the space here. In these cases, we create what is called Bill's Island. What is this Bill's Island is, we remove a portion of the bone, sinus plate, and then we press the sinus, we break it, so that we can push the sinus posteriorly and then get the space into this area. So that is called Bill's Island. See here, there is no dura. I cannot show that. Okay. See, there is no dura. If I go here, this is the posterior canal bone separating the posterior canal fossa. If I do this, I am entering into the posterior canal. There is no dura here. If dura is there, then we could have seen that. Okay, but this is the position of the endolymphatic sac. Okay, and now I will start removing other hair cells. So now you see the posterior canal wall is here. Okay. Posterior semicircular canal is here. Okay, this is a lateral semicircular canal, and we can see superior semicircular canal here, but the arch is not yet clear. Okay, because there are still some cells here. So once I remove these cells carefully, then I can go ahead, then I can see the superior canal. So, but before that, I want to show one more technique, that is posterior canal wall occlusion. Posterior, that is done for intractable BPPV. For this, we have to open the posterior semicircular canal. Okay, I am running the burr in the direction of the posterior semicircular canal. You see that? Until I open that at one area, and then I can occlude that with, you know that BPPV is, most of the cases it is amenable to the maneuvers, but when it is intractable and with maximum medical treatment, if patient continues to have, then we open the canal and occlude the canal. For that, first you make the blue lining. Now you see there is, actually I am getting this thing. Any doubts? So I'm using most of these procedures with diamond burr only. See, that is the posterior canal. So while doing endolymphatic sac, we should not open this. Okay. Now I have opened here to show how a posterior canal occlusion is done. So once we open like this, the membranous labyrinth, that is, should not be injured.
Okay.
Only the bone should be exposed, and the endosteum should not be injured. Endosteum should not be injured, and then we have to compress with either fat or with muscle or with gel foam, so that the posterior semicircular canal, bony canal gets occluded, and the free floating particles will not move inside. So that is the philosophy of treatment for intractable BPPV. Okay, if it is posterior canal wall BPPV, but sometimes the BPPV can be because of all the canals. So then we do what is called triple canal occlusion. In that case, we open the posterior canal, we open the lateral canal, and we open the superior canal and block it. Okay, that is called triple canal wall occlusion. These are rare procedures which are done in intractable BPPV. Today, BPPV is majority of the times it's a medical disorder, amenable for amenable for maneuvers. Okay, yeah. Now I'll go ahead with the labyrinthectomy. So already I opened the posterior semicircular canal, and I will trace it. So all these semicircular canals will have ampullary end and non-ampullary end. Okay. Can you see that?
Yes.
Slowly I'm tracing. Tracing up to there.
Okay.
They will leave up to there. Then I will open the lateral canal. Okay.
Okay.
So all these procedures are being done with intact canal wall and with facial nerve in under vision. That's very important. So this is the hardest bone of the body, the labyrinth.
Yes.
Temporal bone is the only bone in the body having lodging 3 sense organs,
Right.
isn't it?
Yes.
That is hearing, balance, and taste. Yeah, now the lateral semicircular canal is opened. You see that? So that again has ampullary and non-ampullary end. Can you see that ampullary end there?
Yes.
See, very close. The ampullary end of the facial canal or lateral semicircular canal is close to the facial nerve. You see that? In fact, all the semicircular canals are very close to the facial nerve. Different portions of the facial nerve. Now I will start tracing the superior canal. For that, some more hair cells just below the tegmen I'll remove. So tegmen is injured here.
Yeah.
Okay. So it forms like an arch. Okay. Little low lying. Tegmen is little low lying here. This area.
Okay.
There is hardly any space between the superior canal and the tegmen there. Here they actually breach there. So the non-ampullary end of I'm tracing the non-ampullary end of the posterior canal, and that fuses with the non-ampullary end of the superior canal to form the crus commune. Hello.
Yeah. Yeah.
So I'm near that crus commune area.
Enter the center of interest.
Huh? Centering?
Now we can see the posterior canal.
Yeah. See, the posterior canal is good. The non-ampullary end is going there. And it will join the non-ampullary end of the superior canal. Small suspension. See that? Can you see that?
Yes, sir.
So non-ampullary end. Once all the three semicircular canals are skeletonized and opened, that finishes labyrinthectomy actually. But to remove the saccule and utricle, you have to open into the vestibule.
So normally in your digital business, sir, so what are the indications, sir? Labyrinthectomy. Open your business.
Intractable mean ears and ear is dead ear. Patient is not having serviceable hearing.
For vertigo.
For vertigo only. Because the patient's hearing is lost because of the disease. Superior canal is little tricky sometimes.
Yeah.
To get the blue line of the canal is sometimes tricky.
Yeah, because the dura is
Yeah, sometimes it is
normally
tricky.
you have to retract the dura.
Yeah, sometimes you can't trace it like the posterior, see, like that, like posterior semicircular canal. But ideally, we'll get a. Yeah, here it is opening. You see that? Now you are opening there. So that is the ampullary end. Ampullary end, how to identify, is slightly larger. You see the ampullary end of the superior canal is slightly larger. All the ampullary ends are slightly larger than the non-ampullary ends. So now I am wash. Now I will trace the superior canal. Quite deep it is, okay? Is it clear now?
Yes, sir.
So now this is, I am tracing the, okay. And this should join the non-ampullary end of the posterior canal to form the common crus or crus commune. Section. Then these ends are meeting now. You know,
Yes,
it is coming there.
you can also see a bit of vestibule also.
Yeah. Yeah. So I'll identify the structures now. Yeah, equally. Thick. See, this is the posterior semicircular canal. This is the ampullary end. Okay, going below the facial nerve. That's how it is related with the facial nerve. And this is a non-ampullary end coming here and joining the non-ampullary end of the superior canal. Okay, and it's going here. This is a non-ampullary end again going below the facial canal. Okay, and opening into the vestibule. And this is the superior canal and this is the ampullary end of the superior canal, and it opens into the vestibule, and this forms the Meigs dot, macula superioris, Meigs dot on the vestibule, and this is a very important landmark because we have to stay, if we want to open the internal auditory meatus, we have to stay below this. Okay, is it okay? That forms the Meigs dot. Is it clear? So this is an important landmark. We have to stay below this level for the exposure of the internal auditory meatus through the translabyrinthine approach. Okay, and this is the lateral semicircular canal dome, and it is going here. This is the ampullary end. Okay, lateral semicircular canal. Yeah, correct. So, yeah. So this is the ampullary end, and non-ampullary end I have to open here. Okay, I'll open that. And here, what you can see here, what is this? This is the subarcuate artery. Okay, which comes in the arch of the superior semicircular canal. Subarcuate artery. It's a branch of ICA, and the importance is it is a end artery. Okay, and it supplies the bony labyrinth, membranous labyrinth, cochlea, and all these things it will supply. The subarcuate artery. Okay, it's end artery. Any infraction, there won't be any. Yeah, there won't be any this thing. Collaterals won't form. Yeah. So I'm searching for the other end of the lateral semicircular canal. Okay. Okay. So now it is opening up. You see that lateral semicircular canal? Can see that? And it is in fact, we are entering into the vestibule. That is the vestibule. Yes. Okay. So through the crux commune, normally what we do is to enter into the vestibule, we open through the crux commune. That is safer because it is away from the farther from the facial canal. Okay. Here I might have opened from the lateral canal, but it is ideal to open from the crux commune side. Okay. So there are 6 openings. There should have been 6 openings, but there are in the vestibule there are only 5 openings by 3 semicircular canals, because crux commune is a common opening from through 2 canals, isn't it? So now I'm thinning out all these things and opening into the vestibule. All this it is safe to do with diamond bar. So this is still thick. That's why I'm having difficulty. Facial canal is there. This ridge is still. Opening into the vestibule through the crux commune side. Okay. Once I open the vestibule, I'll widen the vestibule. Then I'll see 2 important structures there: spherical recess and elliptical recess, which lodges the utricle and saccule block. ಕೋರ್ಸ್ ಡೈಮಂಡ್ ಬರ್ಕೊಡು ಚಿಕ್ಕದು. ಕೋರ್ಸ್ ಬರಲ್ಲ. ಓಕೆ. So till now, any doubts regarding labyrinthectomy? I'm leaving a thin bone along the facial canal, isn't it? So all that now you can see by turning the bone, I can show you the elliptical recess and spherical recess. Yeah, see now. Done. So the vestibule is open now. Yeah. Okay. So the canal wall is still intact. Facial nerve is still intact. And we have not damaged the ampullary end of the superior canal. And this is the origin of the superior vestibular nerve. Okay. That forms the Mike's dot. And that supplies the superior canal. While doing the nerve exposure from the internal auditory meatus, then we have to identify the structure and stay below the structure. And once we open the vestibule and we curate all the neuronal elements, that is utricle and saccule, that finishes the labyrinthectomy. Okay. They say if you don't completely extirpate the neuronal elements, there will be residual vertigo. That's the reason one has to open the vestibule and completely evacuate the saccule and utricle. Okay. Okay. So that I finished now. What that Shankar showed us, Shankar showed us through the oval window in a dry bone. He showed this area. Okay. Okay. He showed this area. That is the ampullary end of the posterior semicircular canal. Okay. And now you can see the stapes is here. Can you see the stapes is here? And I am under the stapes. See, if I put this, I can move the stapes. Yes. If piston was here, Shankar had put piston, we removed it. If piston was here, then I would have seen the piston here. Can you see this? No. And yeah, now? Yes. If piston was here, see now, I'll move the stapes from inside. See now, it is moving, isn't it? Can you appreciate the movement? So if piston was here, we could have seen the piston here. And in stapedectomy, we always choose the piston posteriorly because the underlying structure, that is the utricle and saccule are deeper. Okay. There more space, so the long piston will not stimulate them. Okay. And these are the recesses, elliptical recess and spherical recess. Okay. Okay. And so endolymphatic sac, if it was sometimes in a wet bone, the endolymphatic sac, from here it forms a sac, then it runs below the crus commune. Sometimes it will be clear below the crus commune and opens into the duct somewhere here. So that is the vestibular aqueduct in the medial wall of the vestibule, and cochlear aqueduct will be below. For that we have to remove some more of this bone. I think Dr. Uday will be showing you tomorrow. So we leave this bone at this stage. So we have kept all these procedures are done with intact canal wall. You see the canal wall is intact, facial nerve is intact. Okay. So this is the finally I will show you all the structures. Okay, this is the facial nerve horizontal portion. First genu. This is the vertical portion. It is intact. Okay, the posterior canal wall is intact. Stapes is there. Stapes is there, and extended round window is here. Extended facial recesses happened here. Okay, and there is a breach here in the tegmen. Okay, because there is no dura, it is looking like this. If the dura was there, probably you would have seen as a complete this thing. And posteriorly, we can see the sinus plate and the endolymphatic area. Okay, any doubts before we close?
Yes. No. Clear, I think.
Clear, no?
Yeah.
And you see the this is the varia tunnel.
Yes.
Okay, which is quite far, and yeah.
Okay.
And tomorrow, I think the other procedures like exposure of the nerves in the internal auditory meatus through the translap approach,
Right.
then facial nerve rerouting, then a middle fossa approach,
Yes.
and cochlear drill out, then carotid drill out, jugular drill out. All these will be shown by Dr. Uday. So all the dissectors now can proceed to the lunch, and they can start dissecting. Today we expect you to do until this day. Okay, and we have time up to probably 6:30, and you can keep